We'll start our presentations by introducing Dr. Alexis Réjean in French, or Alexis Réjean in English. We are honored by his visit to Cairo. It's a great pleasure to host him in Cairo and Alexandria as well. Let me introduce his background. He's a specialist in internal medicine in the Research Center for Systemic Rare Diseases in Cochin Hospital, Paris University, France. He developed interest in vasculitis since his PhD, specifically in giant cell arteritis pathogenesis. He studied the proteomics and identified the antigenic targets of vascular smooth muscle antibodies. Then he worked on the therapeutic prospective trials on the value of endothelin inhibitors or inhibition trials in this field in Paris University, and then the comparison of methotrexate and tocilizumab in the same field. He also lectures in Université de Paris Cité. We are honored to have you with us, Professor Alexis Réjean, and the stage is all yours. Please, we are all anxious to listen to your presentation.
Okay, thank you. Thank you. So thank you very much. I'm very pleased to be here and very honored to be in Alexandria today for this talk. So I will have a talk on giant cell arteritis and Takayasu arteritis. I will try to make a focus on what's new, what is recent, what is important, and I'm not going to deal with all the aspects of large vessel vasculitis. So first, just as a reminder, the classification of vasculitis. We are going to talk about large vessel vasculitis, and specifically two of them, giant cell arteritis and Takayasu arteritis. So first, giant cell. So it's clearly a large vessel vasculitis. It's going to involve its aorta and its main branches. And on histological level, you can see inflammation in the three layers with giant cell. Usually it affects patients who are older than 50, but in main studies, age is approximately 75, and prevalence with north to south gradient is approximately 1/4,000. Sex ratio is approximately 2 to 3 women for 1 man, so female predominance. So I'm going to talk about clinical symptoms, about temporal artery biopsy and imaging, and about treatment. First, if we go back to clinical symptoms, the typical presentation of patients with GCA is headache, jaw claudication, tenderness of temporal artery, loss of arterial pulse, and patients often experience polymyalgia rheumatica. These symptoms are found in approximately 40 to 50% of patients. And a quarter of them will have ophthalmic symptoms. A quarter have symptoms but are not going to have sight impairment, hopefully. And the main characteristic of visual impairment is anterior ischemic optic neuropathy and central retinal artery occlusion. Unfortunately, some patients, approximately 10% of patients with GCA, will have the visual disturbance as a first symptom. Often, when you ask them, what are your symptoms, you can still find a mid-general health impairment or some headaches, but unfortunately, 10% of patients will enter the disease with visual symptoms. It's a sight-threatening emergency, and treatment has to be introduced very quickly. In these patients, you always have to be sure that there is no cardiac arrhythmia or vascular bleed, because it might be a differential diagnosis. And there are some other systemic features: fever, loss of weight, moderate general health impairment, and other symptoms such as ENT symptoms, stroke, myocardial infarct, or no inflammatory or marker elevation. However, these other presentations that we find most often in hospital are quite rare. When we want to have a diagnosis of GCA, we have to go back to the classification criteria. These criteria were established in 1990, and they should not be used for diagnosis purpose. And it's really something which is important. It's only classification criteria in patients with vasculitis. So age over 50, raise in ESR, abnormal temporal artery examination, unusual headaches, inflammatory infiltrate upon temporal artery examination. These criteria lacks specificity. They do not take into account the progress in vascular imaging, and I think that it's no more useful. In order to reach a diagnosis of GCA, there were some attempts which were made recently in order to have a clinical probability score. As you can see on this slide, on the left part of the slide, there are the different criteria with age, duration, onset and symptom, laboratory results, symptoms, visual sign, etc. And there is also a question regarding alternative diagnosis. With each of the criteria, you are going to have some points, and there is an optimal cut point at 9 in this manuscript. So as you can see, it might be helpful in order to obtain a diagnosis of GCA, but I think that there is still a need for a proof of vasculitis. This proof of vascular inflammation can be obtained by different means, either temporal artery biopsy, or it can also be obtained with imaging. And in my daily practice, I have no preference for either one or the other. You can either choose US, MRI, PET-CT, CT scan. I mean, there are many ways to prove that there are vascular inflammation. And in fact, the main question is which one is available, when, and where are the symptoms? Clearly, it's going to change according to cranial vessel or extracranial vessel. Second thing is that there is a rapid decrease in sensibility after GC initiation, and you have to organize this imaging or temporal artery biopsy as soon as possible. I think that there is longer time to organize temporal artery biopsies than imaging, only a few days with imaging, and it can be 1 week or 2 weeks long for biopsy. So first, just a quick look on biopsy. Left part is normal temporal artery. You can find the lumen of the vessel. You can find the 3 different layers with internal elastic lamina. And on the right side of the slide, you can see that there is inflammation throughout in the 3 different layers, so it's panarteritis, with giant cells, which are in the middle. I wanted to show you, but it seems to be difficult. And there is this spot, which is the hallmark of inflammation in the different layers. So here is one of the main way to prove vascular inflammation. Regarding biopsy, there is still a question, is the longer the better? So in this study from Alfred Marr, he studied 1,500 temporal artery biopsy from different centers. As you can see, the mean length of temporal artery biopsy was approximately 1.4 centimeters, and only 15% of biopsies were positive. He decided to put one score for positivity in biopsy which were shorter than 5 millimeters, and he expressed the result as you can see, biopsies were far more often positive in biopsy which were longer than 5 millimeters. So in this study, he identified 5 millimeters as the cutoff point between short biopsy and appropriate biopsy. In other studies, it was found that it should be 1 centimeter long, and I think that it's the required length for biopsy. Then we are moving to imaging, and diagnosis of GCA can be made with ultrasound. It was published more than 20 years ago by Schmidt in New England Journal of Medicine that allosine could be a mark of giant cell arteritis. And however, there are really some discrepancy between studies, between centers, and it's sometimes difficult to find the truth with all these studies evaluating US as a diagnosis marker. I think one of the main results comes from the Tabul study, and we concluded that a high clinical probability and a positive ultrasound might be enough for a diagnosis of GCA, and that a low clinical probability and negative ultrasound might be enough to exclude a diagnosis of GCA. MRI can also be used for diagnosis purpose. It was published nearly 20 years ago that a contrast enhancement of temporal or occipital arteries might be hallmarks of the disease. It could be obtained with 3 Tesla MRI. However, in the first studies evaluating MRI, there was a need for a head coil, and we had to improve the technique, and that was what was done recently by our center. We could obtain a diagnosis of GCA with 3T MRI, no head coil, and hopefully we very often use MRI as a diagnosis tool right now. Of course, PET-CT is an excellent modality for diagnosis GCA. It has a high sensibility, between 70 and 80%. It can be due for diagnosis purpose. I will come back later to this notion, but I think we have to avoid PET-CT for follow-up. However, it's quite expensive and availability is sometimes difficult. So according to centers, it can be obtained or no. So right now, in order to obtain a diagnosis of GCA, I think that clinical symptoms are not enough because they are, most of them, unspecific. There is a requirement for a confirmation of vascular inflammation with either TAB, Doppler ultrasound, MRI or CT scan or PET-CT. And for now, there is no additional value for biological marker except, of course, ESR or CRP or fibrinogen. Treatment of patients with GCA is mainly based on glucocorticoid. So the starting dose that we usually have is 0.7 milligram per kilogram or 40 to 60 milligram per day. There is no comparison of both strategies, so it mainly relies on habits. IV methylprednisolone might be used in patients with visual impairment. However, the additional benefit of IV route is of low evidence. What we know is that we have to give GC every day, and alternate day therapy gave some mitigated results and should be avoided. Regarding the optimal length, I'm going to discuss about it just after, maybe 1 year long, but we don't know exactly. What is important with GC treatment is that we have to introduce GC as soon as possible. It has been found that a fast-track clinic with fast introduction of GC therapy could allow drop in visual impairment by 88%. So it's really important, and I think is one of the major changes in the last few years. Regarding the optimal length of treatment with GC, you will see that there are huge discrepancies. When we look at the French Internal Medicine Society recommendation, it's suggested that weaning should last between 18 and 24 months. Looking at Euler recommendation 2020, optimal length should be 2 years. And I think it's also something else which is important, and it's written in the American guidelines. It should be a patient-based strategy. In fact, it's very difficult to know what is the optimal length. There is no definitive markers which give the answer. Maybe younger patients, those with arthritis, are going to experience more relapses, but we don't know at the time of diagnosis. And if we look at the GYACTA trial, which evaluated tocilizumab, there was a group of patients who received GC only for 6 months. In this group, 15% of patients obtained remission. That's why I think that maybe shorter treatment should be considered in patients. However, looking back to observational studies, the mean length of treatment is more than 2 to 3 years. However, there is a link between patient age, length of GC therapy, and occurrence of GC side effects, so we have to reduce the GC therapy. If we want to study antiplatelet therapy, there are mixed results. In this meta-analysis, we could see that there was no benefit from antiplatelet therapy at the time of prior diagnosis. There was a modest impact of antiplatelet therapy after diagnosis and GC introduction. Hopefully, there was no additional bleeding risk. So in my daily practice, I often suggest a very short treatment with antiplatelet therapy. But if we look at the European guidelines, it is said that it should not be introduced except in patients who have another reason to receive antiplatelet therapy. So as I told you, GC are responsible for side effects in more than 80% of them. So we have to find a different strategy to avoid GC use. Methotrexate was one of the best studied treatments, and in this meta-analysis, it was shown that it could reduce first and second relapses, and that it could reduce exposure to GC. In this study, methotrexate was introduced in naive patients. Other immunosuppressants were evaluated in GCA context, and TNF-alpha blockers were inefficient. There were side effects with hydroxychloroquine, dapsone, cyclosporine, cyclophosphamide, and these drugs should be avoided in GCA. And there is really a low evidence of azathioprine or leflunomide. So there is a disappointing result with traditional approach. So recently, and specifically in 2016, 2017, the use of tocilizumab was evaluated in this GYACTA trial, 251 patients, 4 different arms, 2 with tocilizumab, 2 with GC-only strategy. In the tocilizumab arm, it was either every week, 162 milligram, or every other week. GC reduction was approximately between 6 and 12 months according to the arm. And it was found that there was really a a very important impact regarding flares. As you can see, the green and violet lines are those patients who received tocilizumab, and few of them experience relapses during follow-up. So it's a 1 year long therapy, and it was really impressive. However, when we look at what occurs in this patient and what happened in this patient after tocilizumab discontinuation, lots of them experience relapses, at least 50% of patients. So, in my opinion, there is a failure to induce sustained remission with tocilizumab. Despite this failure in inducing sustained remission, in the extension of Gca trial for 3 years, we could see that there is still an outstanding GC sparing effect of tocilizumab. So I think it's really a major improvement in the therapeutic strategy. So that's the way I behave with patients with GCA. There is a risk assessment. Risk assessment might be because of GC-related side effects, and it's going to occur more frequently in patients who are older than 75, in those with a history of diabetes or cardiovascular disease. And we have few information regarding relapse risk during GCA. And clearly, patients who are the younger, below 60, those with large vessel involvement might have more frequent relapses. There is a balance between these two aspects, and according to the result of this balance, I decide to use GC-only therapy or GC with GC-sparing therapy, either methotrexate or tocilizumab. Of course, nowadays, when you decide to use a GC-sparing therapy, it's going to be more often tocilizumab because the level of proof is superior to the proof obtained with methotrexate. And we have to consider the length, and I think that we have to reduce the length of treatment for patients with GCA to 12 months, because you are going to be able to follow this patient with simple symptoms and biological markers. And then either you obtain a success or you have relapses, and you should consider tocilizumab or methotrexate. There are some perspectives in the treatment of GCA. First, anti-IL-17 therapy with secukinumab, JAK inhibitors with upadacitinib, baricitinib, and all these drugs are under evaluation, and anti-GM-CSF mavrilimumab, which is also evaluated in different trials. So I think in the next few years, treatment of GCA is going to change from a GC-based strategy to something else. There was some trial which were made with abatacept, ustekinumab, and anakinra. I'm not going to present all the results of this study, but I think that there were disappointing results with all this strategy. We can discuss a little bit of that, but in this talk I will try to go fast to the next slide. So, and due to the results that I obtained during my PhD, we found that endothelin was involved in the remodeling process of GCA. Maybe there might be an interest of endothelin inhibition in GCA, but it's going to be evaluated in a clinical trial soon. Aneurysm and dissection might occur years after diagnosis or at the time of diagnosis. So you should look for an increase, an enlargement of the aorta at the time of diagnosis, and during follow-up it's unclear what is the best solution for aneurysm detection. What is the time span? I don't know exactly. In my personal activity, I usually evaluate and look for an aneurysm every 3 to 5 years according to the age of the patient, according to the additional risk. Something which is really interesting is that in this study, which was published long ago, a PET-CT was performed at the time of diagnosis, and a CT scan was performed nearly 4 years after diagnosis. And as you can see, patients with FDG uptake positive on the aorta at the time of diagnosis were those who had major increase in diameter of the ascending aorta. It was confirmed in retrospective study. I apologize, there is some trouble with the presentation. It's a study by De Boisson, and he found that patients with PET negative never had an aneurysm. And follow-up is going to be made with symptoms, clinical symptoms, and ESR or fibrinogen and CRP. And I think, apart from the prognostic value of PET scan, PET-CT should not be used during follow-up. So for GCA, I will conclude and say symptoms are often evocative of the diagnosis, but a proof of vascular inflammation is required. There is future research which are needed to improve risk stratification, relapse risk, and risk associated with therapy. For now, treatment is mainly based on GC, but I think that it's going to really change in the next few years. So second part, I'm going to talk a little bit about Takayasu arteritis. So it was first described a long time ago, but it was definitely described by Takayasu in 1975 with an aortic arch syndrome. The histology of Takayasu arteritis is not so different from GCA. However, inflammation is in the 3 different layers, but mainly in the adventitia and media layer. You can find giant cell, and there is a fibrosing remodeling evolution within these arteries. Usually it starts really long before 40, sometimes even before 15. It's a rare disease, of course, approximately 1 over 1 million inhabitants, but there is huge differences between countries. And as you can see, it raises up to 40 per million inhabitants in Japan. There is a female predominance, 90%, and it affects mainly the aorta and its main branches. Looking again at the classification criteria, you have the 6 of them: age below 40, claudication, decreased brachial artery pulse, difference in systolic blood pressure between arms, vascular breath, and arteriogram abnormality. I think that, again, you need to use diagnosis criteria, and I should suggest to use the Ishikawa criteria, which I think are the more useful, with an obligatory criterion, which is the age, 2 major criteria, which might be either left or right mid-subclavian artery lesion, and minor criteria. And minor criteria are just here. You can find them very easily. EGYSIR, carotid artery tenderness, hypertension, aortic regurgitation, pulmonary artery lesion, left mid-common carotid lesion, distal brachiocephalic trunk lesion, descending thoracic aorta lesion, abdominal aorta lesion. So when you make the diagnosis of Takayasu arteritis, you often have a delay which can be of many years. As you can see here, 42 months between start of symptoms and diagnosis. It's due to the unspecific initial symptom: pain, fatigue, dizziness, high blood pressure, claudication, which are not so easy identify, and specific chest pain or carotidopnea, which is, I think, one of the good clinical symptoms. In fact, at the time of diagnosis, first symptom, during follow-up, there are very different symptoms, and it's quite difficult to evaluate the clinical activity of the disease with clinical symptoms. It can either be cardiovascular, constitutional, central nervous system symptoms, laboratory abnormality, and it's difficult to find a solution. Regarding the extent of aortic involvement, different types were described. Here are 5 different types. However, I don't think that it's very useful in clinical practice because it's not going to change your diagnosis strategy and follow-up of this patient. One thing which might be important is that the type of vascular involvement, type 1 to 5 on this slide, might change according to the race of patient between white patient, North African patient, and black patients. So you have to evaluate the vascular extent of the disease. There are very different ways to evaluate the disease. CT scan with a thickening of the arterial wall. MRI, same. TAP CT with uptake which is increased compared to liver. US Doppler with the allosine same as GCA, and angiogram. I think personally that you have to forget angiogram as often as possible. With this vascular extent evaluation, at the time of diagnosis, I think that a TAP CT is useful because it's going to show you where are the abnormalities of Takaysu arteritis, and it's going to be useful for follow-up purpose. So I usually have a TAP CT at the time of diagnosis just to have the vascular extent. And then during follow-up, I most often use MRI and US Doppler to be used in this young population. So here is the Doppler with ultrasound sign, CT with thickening of the arterial wall, of the aorta, and another one, and MRI with aorta enlargement and thickening of the wall, and PET CT images. Angiogram should be avoided because you are going to repeat very often this exam, mainly one each year, and it's not possible to have such invasive procedure. In order to evaluate the activity of the disease, it's still a question of matter. You can use PEDVA score, physical global assessment score. It might be useful, but it's quite difficult in clinical practice. When you look back to the recommendations that were made by the EULAR Congress, it said that ultrasound, PET, MRI, or CT might be used for diagnosis or follow-up of patients with Takayasu arteritis, but in fact they put in the same thing GCA and Takayasu, and I'm not sure that all the recommendations that were made apply to patients with Takayasu. So you have to be cautious with this recommendation. In order to evaluate the activity of Takayasu arteritis, there is a score, NIH, with systemic features, elevated ESR, vascular ischemia or inflammation, and typical angiographic features. It's quite useful in clinical practice, and recently another score was proposed with, as you can see in table 4 and at the lower part of the slide, IESR, NIH criterion 1, NIH criterion 4, and carotidopnea. These 4 markers might be accurate to evaluate the activity of the disease, but it's still a question that has to be answered. According to treatment of Takayasu, it's mainly based on GC, but we suggest in our daily practice to use conventional immunosuppressant. mainly methotrexate, sometimes azathioprine, and less often mycophenolate or cyclophosphamide. Here are the doses of GCs that we use in Takayasu arthritis. However, despite this treatment with GC and methotrexate, there is some relapse which were observed in this patient, and it was suggested that anti-TNF therapy might be useful. And as you can see, this first report of 20 patients, some could obtain a remission or a sustained remission. However, as you can see, some relapsed despite the treatment with anti-TNF. In this meta-analysis that was made more recently, it was found that it could be the efficacy of anti-TNF therapy was found in approximately 90% of patients. However, when you follow these patients, relapse occur in approximately half of them. So there is a need for other treatment, maybe tocilizumab therapy, and it was found that it could really be useful. And very recently, a head-to-head comparison of tocilizumab and anti-TNF therapy was made, 209 patients receiving either one or the other. And in fact, there was no difference in complete response rate, relapse occurrence, treatment discontinuation, and side effects occurrence. So in fact, it's according to the availability, the choice of the doctor and the patient, and I don't have any information to support the use of one or the other. There were some aspects which were associated with clinical remission, age below 30, vascular sign, prednisone daily dose more than 20 milligram, and some signs were associated with relapses, supraortic branches and thoracic aorta involvement, systemic sign at baseline. During follow-ups, so as I told you, there are a lot of relapse with vascular complication in nearly 1/3 of patients. Death might occur in 5% of them. So there are two different ways to treat vascular stenosis. First one is endovascular treatment. It is efficient, and the usual complication of endovascular therapy is restenosis. And the second one is open surgery, which is also very efficient, and it can cause stroke in some patients. I think one of the key messages is that there is no definitive proof that one is better than the other, and it might be evaluated depending on the location of the stenosis, the accessibility, etc. And the second message is that you have to check that your patient is in clinical remission before deciding a vascular procedure. As you can see on the left part of the slide, those who had no complication of the procedure were those with the lowest result in C-reactive protein and fibrinogen. The prognosis is quite good, although slightly impaired as compared to general population, and the prognosis markers are retinopathy, high blood pressure, aortic regurgitation or aortic aneurysm, and there are some death causes that are cardiac failure, myocardial infarct, stroke, kidney failure. As you can see on the right part of the slide, there is still a modest impact on survival in patients with Takayasu arthritis. So in order to conclude, Takayasu arthritis is a rare disease with atypical sign at the time of diagnosis, so you have to be aware of the possibility of Takayasu arthritis in order to obtain diagnosis. There is no well-defined criteria for disease activity, and I think it's going to be really a matter of research in the future. Follow-up is unclear, and what I do usually is to use MRI and UF ultrasound every year. And prognosis has changed with new therapeutic strategies and increased experience of doctor, but there is still some improvement to be made. So thank you very much, and thank you for your attention.
Thank you very much, Alex. Brilliant presentation and very perceptive. We have some time for questions. I see that there are many questions here raising their hands. So we have 5 minutes or 6 minutes for questions.
First of all, thank you so much for this informative presentation. I have 2 questions. One for the GCA. I have already patient. He was in complete remission using tocilizumab, and he was off steroid. He has extracranial with aortic aneurysm. We have a problem that we don't have tocilizumab anymore in Egypt due to COVID. I tried Barry, but he failed, and I tried adalimumab, still he failed, and he's already on methotrexate. So in your personal opinion, what should I do next?
Good question. No, it's really difficult. I must confess that we usually use a combination of GC and methotrexate, and that's what you did. So I'm not, from a personal point of view, I'm not very confident with abatacept, because clearly there was some evidence that it might be useful. The design of the study was really difficult to understand, and it might be an option if you cannot obtain tocilizumab clearly, because I think that it's the treatment with the best level of evidence that can be used today. So I completely agree with you. And then you are going to adjust clinical remission with GC dose, which is not a good thing to do, but I think that there are not many options.
My second question is Takayasov, a patient in already remission. How often do you use MRI or ultrasound for follow-up?
That's what I suggested, but it's only a suggestion because there is no proof that it's the right way. I usually use MRI and ultrasound once a year. I think that if everything seems to be, if the patient seems to be in remission in outpatient consultation, then it seems to be enough. But I mean, you have to be cautious with such patients because it's really difficult to evaluate the activity of the disease, and sometimes there is nothing, and when you evaluate with MRI or ultrasound, you can observe a stenosis despite no inflammation, no symptom, and it's really difficult.
Thank you. Dr. Dalia Faiz.
Okay. Thank you for your informative lecture. I want to ask you about Takayasov disease. I have patient resistant for treatment, has inflammatory marker, high inflammatory marker, and I give him infliximab. He has resistant hypertension and complain of chest pain. So we advise, collaborate, ask a doctor, cardiologist. He asked to do catheterization, coronary angiography. After he did the coronary angiography, the blood pressure sudden drop from resistant hypertension 170/20 to 90/70. Can you explain to me, you said in your lecture that it is, you don't prefer, it is better to avoid angiography for this patient. What happened for this patient?
No, I just suggested, maybe I wasn't clear, I just suggested that angiogram should not be used for diagnosis and evaluation of the activity. We usually use CT scan as an evaluation with either myocardial CT scan to have an evaluation of coronary artery or elsewhere. But we try to avoid angiography because angiograms because it's quite a huge procedure. In your patient, I understand that it's difficult. Most often, hypertension is a reaction due to stenosis, and you may have done it before. Have you checked that your patient does not have a renal artery stenosis, because it might be one of the causes for this resistant blood pressure? And I understand that sometimes angiography is a good treatment, and coronarography might be used. It's just for diagnosis purpose and evaluation of the activity of the disease that I would avoid this kind of exam and try to use a non-invasive procedure if possible.
Thank you.
Thank you, Professor Rejon. I think we have to move to the second speaker because we are on a tight schedule. The second speaker will be, thank you very much. If anybody has some questions, you can address Professor Rejon during the break. The second speaker will be Professor Dr. Luca Kartuccio. Is he online now?
Yes.
Yeah, how are you, Luca? We are pleased to introduce Dr. Luca Kartuccio. Actually, his presentation makes a great importance to us. Luca was entrusted with the organization of the Sjogren Symposium, which takes place every 4 years, but this year it took place in Roma 10 days ago. Because of the COVID, it was 1.5 year delay. I owe him a lot for inviting me to share with this symposium together with Professor Salvatore. He was an organizer, and we are happy to have the update, the most recent update of Sjogren. I think the most important thing is that we have to change the name to Sjogren disease and not syndrome. This is the most important thing. Luca, Dr. Kartuccio, graduated from the University of Udine in Italy. His main work was on the etiopathogenetic and therapeutic features of rheumatic diseases, with particular interest in the B cells, in cryovasculitis, Sjogren's nowadays disease, and rheumatoid arthritis. He was awarded many awards, like the Young Researcher Award in the Italian Society of Rheumatic Disease of Rheumatology in the year 2008, and he was also awarded the Euler Abstract Award on the year 2014. He has more than 200 works in rheumatology, the PubMed, and we have conjoint activities with Professor Luca. He is on the editorial board of our Cairo University Journal of Advanced Research, which is now enjoys an impact factor of over 11. And I leave the stage for Professor Dr. Kartuccio to present his topic on glandular and extraglandular, as well as the recent treatment approaches to Sjogren. Please proceed, Professor.
My talk will cover three. Welcome to everybody. I'm very glad to be here, and I'd like to thank the scientific organizers of the Congress, and in particular my friend, Professor Jafar, who invited me for the second year. My talk will cover three main features of Sjogren syndrome after a summary on key features of the disease. First, the glandular, and the second, the extraglandular features, and finally some novel upcoming therapies for Sjogren, in particular those targeting B cells. Before starting, I would remind you that milestones in the story of Sjogren syndrome, in particular the 5 most important steps. The first, most clear description of the disease by Heinrich Sjogren in 1933. Heinrich reported 19 women with Zika symptoms, and 13 of them with probably overlapping rheumatoid arthritis. The link between Sjogren and the lymphoma by Norman Talal, reported in 1964. The discovery of anti-Rho antibodies in Sjogren syndrome, and finally the long story of classification criteria which finally led to the last 2016 ACR Euler classification criteria currently applied in all the epidemiological studies and clinical trials. Up to now, Sjogren syndrome remains an heterogeneous disease lacking disease-modifying drugs for sicker features or licensed drugs for extraglandular manifestations. And the drugs we are currently using for Sjogren carry a low level of evidence. Indeed, the main lines of research in this field are really to harmonize among clinicians the description of the disease, to find out the composite scores of responses, and to stratify patients for clinical trials, and finally to deeper dissect at molecular biological level the heterogeneity of the disease. The other point is to clarify what is Sjogren syndrome. Based on the definition of one of the historical fathers of the disease, Charalampos Motsopoulos, it is an autoimmune epidermitis, thus the inflamed or activated epithelium plays a central role in the pathogenesis of the disease, together with the autoimmunity, here represented by the dysregulated B cells, which produce autoantibodies and immune complexes by interacting also with T cells and dendritic cells. But the disease is also a lymphoproliferative disease, from benign lesions to neoplastic lymphoproliferation characterized by lymphoma of the malt tissue in particular. And I remember you that lymphoma has been linked to Sjogren from the beginning of the story, before the discovery of the autoantibodies associated to Sjogren syndrome. As you can see in this table, this is the largest study on the risk of lymphoma in autoimmune disease coming from the Interleaf Consortium. And Sjogren syndrome showed the highest risk of lymphoma, mainly in the parotid glands and of MALT type. Notably, the risk was 4 to 5-fold increased if compared to the general population. And also in our Italian region of Friuli, Venezia Giulia, in over 2,000 patients followed from 2002 and 2017, the risk was really the same, 4-fold increased. Therefore, the risk is intrinsic to the disease, we suspect, and not likely influenced by local factors. Importantly, in Sjogren syndrome, the risk of MALT lymphoma has been clearly explained by parotid gland enlargement, low level of C4, leukopenia, and the presence of both anti-SSA and anti-SSB antibodies, thus strictly linking MALT tissue, autoreactive B cell clones, and the loss of immunosurveillance. And finally, even mortality in Sjogren syndrome can be predicted by the presence of some biomarkers of B cell activation, such as serum cryoglobulinins, low C4, low C3, monoclonal gammopathy, lymphopenia, and the presence of anti-SSB, with the highest risk when the biomarkers are more than 1. Besides the activated epithelium B and T cells, other crucial actors and potential targets by novel treatments have been identified so far, including plasmacytoid T cells, type 1 and other interferons, and cytokines favoring B cell survival as BLyS or BEF. All these actors work in a particular microenvironment, which is the salivary gland tissue that becomes a mucosa-associated lymphoid tissue over time, where immunological alterations are maintained and even protected. Thus, the goal is to target immunological alteration in the target tissue. That means also targeting the microenvironment that sustains the autoreactivity. And among the cytokines that maintains B cell autoreactivity, BAF is becoming a very promising target for Sjögren indeed. Sjögren syndrome, you know, is the autoimmune disease carrying the highest levels of BAF. In the BAF transgenic mice, salivary glands are enlarged with lymphocytic infiltrates. BAF correlates with the level of rheumatoid factor, the level of systemic disease activity, and the highest grade of lymphoproliferation, the highest levels of BAF is. In two papers published between 2015 and 2016, we reported the favorable results of belimumab, the monoclonal antibody anti-BAF, on systemic activity in 30 patients recruited in two centers, our center of Udine in Italy and the center of Professor Mariette in Paris. Glandular lymphadenopathy, articular and biological domains contributed most to the decrease of this dye, and also the clinical and laboratory relapse after discontinuation supported the efficacy of belimumab in Sjögren syndrome, although in a single-arm trial, preliminary trial. And finally, when we are approaching the management of Sjögren syndrome, we have to keep in mind that Sjögren syndrome and autoimmune epithelitis both often associated with lymphoproliferation, that the Sjögren syndrome is a multi-tissue disease and an autoimmune systemic disease. We need to consider the clinical pyramid of Sjögren syndrome, characterized by Zika symptoms in almost all the patients, glandular swelling in 30% of patients, extraglandular manifestations in 15% of patients, and lymphoma in 5 to 9% of patients. Importantly, Zika syndrome is the sole manifestation in more than 50% of our patients. The current classification criteria of Sjögren clearly define the core of the disease, and they require the presence of a positive lip biopsy with a focus score of 1 or more, and or the presence of anti-SSA antibody. However, for applying these criteria, the patient has to meet the inclusion criteria, which are the presence of dry mouth or dry eye, or the positivity of at least one clinical domain of DSDI. Classification criteria published by Vitali in 2002 clearly define the validated questions to evaluate Zika symptoms in our patients. For the ocular symptoms, you require at least one of dry eyes for more than 3 months, gritty sensation of sand of gravy in the eyes, need for tear substitutes more than 3 times a day, and for oral symptoms, at least one of dry mouth for more than 3 months, recurrently or persistently swollen salivary glands as an adult, needs liquid to swallow dry food. Both oral and ocular dryness are highly represented in Sjögren syndrome patients. However, it is possible that the patient complain of one rather than the other symptoms, oral dryness being more specific for Sjögren syndrome than ocular dryness. Oral dryness is characterized by dental caries, frequent dental caries in atypical sites, cervical or incisal surfaces, dysphagia, taste anomalies, lingual fissures, difficulty in speech and chewing, hoarseness, angular cheilitis, erythematous lesion of the hard palate, red tongue, with atrophy of the papilla, with candida, due to candida infections. Confounders may be aging, some comorbidities such as diabetes, and some drugs such as diuretics, beta blockers, or antidepressants. Regarding ocular dryness, symptoms are often non-specific. The subjective symptoms in dry eye disease are redness, burning, stinging, foreign body sensation, itching, photophobia, and subjective and objective clinical findings do not always correlate. Dry eye disease can be complicated by ulcerations and corneal perforation if not adequately treated. And finally, patients often describe nasal and skin dryness with itching, bronchitis, recurrent pneumonia, and vaginal Zika that dramatically interferes with the life in a couple. I remind you that Sjögren's dry eye disease is classified among the lacrimal tear deficiency, aqueous type of dry eye disease that is very different from the evaporative type of dry eye disease, such as meibomian gland disease. In this category, the category of aqueous deficiency, the main causes are distinguished in lacrimal deficiency, reflex hyposecretion, and systemic medication. In the first class, you can see aging, sarcoidosis, lymphoma, IgG4, age, CV. In reflex hyposecretions, diabetes, contact lens, small fiber neuropathy, herpetic infections, for example, and finally in systemic medications, beta blockers, diuretics, antidepressants, anticholinergics, antiarrhythmics, antihistamines, and also bisphosphonates. Of note, while breakup test could not distinguish between aqueous and evaporative ocular dryness, Schirmer test, type 1 Schirmer test, is positive only in the aqueous type of ocular dryness, thus underlies a problem with tear production. Finally, up to 30% of patients with Sjögren syndrome can show major glandular enlargement during their life, mainly parotid swelling. It can be transient or persistent, lasting at least 2 consecutive months. This feature is clearly recognized as a risk factor for multiple lymphoma, especially if the swelling is rock hard. And parotid biopsy in this case is absolutely mandatory, and pathology needs to investigate for IgG4 disease, sarcoidosis, and also salivary gland cancers other than lymphoma. Coming to the extraglandular manifestations, clinical data from different large cohorts of Sjögren syndrome, including the Italian cohort published in 2014, the articular, pulmonary, cutaneous, and neurological involvement are the most frequent extraglandular manifestations in Sjögren, and also they are the most represented clinical domains in clinical trials as well. However, the great challenge for clinicians is the great heterogeneity observed in each individual domain that hides different pathogenetic mechanisms and explain different patterns of responses to such a drug. For example, look at pulmonary involvement, where you can find the features of interstitial lung disease, but also cystic lesions, amyloidosis, bronchiolitis, or even mild lymphoma. The same for muscular involvement, where you can see a pure type of Sjogren's syndrome associated myositis, polymyositis-like, but also inclusion body myositis. The same for peripheral neuropathy. You can see sensory motor, cryoglobulinemic peripheral neuropathy that is totally different from pure sensory neuropathy characterized, for example, by small fiber neuropathy. Regarding the musculoskeletal clinical features, even if frequent, the articular involvement is rarely characterized by frank arthritis. It usually involves the hands. It is not erosive, except when there is an overlapping rheumatoid arthritis. 4% of patients with rheumatoid arthritis can show Sjogren's syndrome. On the other hand, 2 to 3% of Sjogren's syndrome can develop a frank, overt rheumatoid arthritis. There are a few cases of Charcot arthropathy in Sjogren's syndrome. As concern myositis, in the Italian cohort and also in the French cohort, it is estimated around 1%, so rare manifestation. And I suggest to perform muscle biopsy in case of suspected myositis and Sjogren's syndrome, since there is the possibility you could find, as said before, an inclusion body myositis, which is known to be very resistant to immunosuppressors. The most frequent skin manifestation in Sjogren's syndrome is a Raynaud phenomenon, usually not so bad as in scleroderma, usually not complicated as observed in scleroderma. Purpura is the other frequent cutaneous manifestation, usually associated with hypergammaglobulinemia or cryoglobulinemia. In this last case, it is recognized as a risk factor, strong risk factor for lymphoma, and lymphoma diagnosis has to be ruled out when cryoglobulinemic purpura is present. And the cryopurpura, much more than hypergamma globulinic purpura, can be associated to visceral involvement, peripheral nervous system involvement, or glomerulonephritis. Other skin manifestation comprises annular erythema, subacute lupus, autoimmune urticaria, all of them associated with the anti-SSA antibodies. Pulmonary involvement in Sjogren is very heterogeneous, as stated before, showing different patterns of involvement from bronchial to bronchiolar, interstitial or parenchymal pseudonodular features. Since the symptoms are very specific, it is very important to integrate clinical features with imaging studies, including CT scan, but also CT PET, to rule out mild lymphoma, and even performing lung biopsy, transbronchial or CT guided if needed. Lymphocytic interstitial pneumonia is the most specific interstitial involvement in Sjögren, but less frequent than the other interstitial histopathological patterns. As well as the pulmonary involvement and neurological symptoms, both peripheral and central, can be present at the onset of the disease and can mask Zika symptoms. Pure sensory neuropathy is the peripheral most frequent manifestation, and in particular when patients complain of widespread pain, in particular at the lower limbs. Small fiber neuropathy should be always investigated with QST and skin biopsy in 3 sites on the lower limbs. The electrophysiological study is usually negative, of course, and mononeuritis as well as sensory motor neuropathy are rare manifestations but associated with more aggressive disease, often vasculitic disease. Central system involvement is very rare. In our experience, we diagnosed patients with transverse myelitis, in particular neuromyelitis optica associated with anti-aquaporin 4 antibodies and multiple sclerosis-like lesions. Similarly, the urinary tract and renal involvement are rare. The most frequent involvement is the renal tubular acidosis type 1 with histological features of interstitial nephritis, tubular interstitial nephritis. Usually the course is indolent, does not require immunosuppressive drugs or corticosteroids, but only support treatment. You can also observe cryoglobulinic glomerulonephritis importantly with a subacute and insidious onset, different from the acute onset of ANCA-associated vasculitis. And finally, the interstitial cystitis, very painful and disabling manifestation, often associated with fibromyalgia. Finally, in the gastrointestinal features, often under-recognized by clinicians, I would like to underline the importance to study the stomach by AGDS to rule out gastric localization of lymphoma when symptoms are present, and to exclude IgG4 disease when autoimmune hepatitis or chronic pancreatitis has been suspected in Sjögren syndrome. So the last part of my talk on the novelty in the treatment. I would remind you the last recommendations on treatment, which were published in 2020. They reported the lack of licensing of effective biologic drugs for Sjögren syndrome, an overall low level of evidence, and that B-cell targeted therapies, in particular anti-CD20 therapy, showed efficacy in the great majority of studies, open studies, in at least one of the systemic outcomes analyzed in terms of global response, organ-specific response, SDI reduction, corticosteroid reduction. And there are more than 400 Sjögren syndrome patients treated with rituximab with an acceptable safety profile up longitudinal, and in particular, cryoglobulinemic manifestations are very responsive to B-cell targeted therapies in Sjogren's. In the following two tables, you can see the possible role of rituximab as first, second, on third line in some glandular swelling in particular, and extraglandular manifestations in polysynovitis, for example, when hydroxychloroquine, glucocorticoids have failed, and also in rheumatoid arthritis like features, or when rheumatoid arthritis has been diagnosed in overlap with the Sjogren's syndrome. But also rituximab is effective in cutaneous manifestations, in particular in cryoglobulinemic purpura, and also in cryoglobulinemic glomerulonephritis. The other manifestation where rituximab is a good choice, can be a good choice, is peripheral neuropathy when cryoglobulins are demonstrated in the blood, and also in the hematological manifestation, rare hematological conditions such as thrombocytopenia or hemolytic anemia, conditions where rituximab has been effective also in lupus patients. Importantly, only in 2022, the first positive phase 2 randomized control trial has been published in Lancet, and this trial showed the preliminary efficacy of ianalumab, a fully human anti-BAFF receptor antibody, on the systemic disease in Sjogren's syndrome. This is a great achievement, came after a long series of failed placebo-controlled trials with biologics and even small molecules. I remember the last trial in Sjogren where also filgotinib failed in systemic disease activity, in decreasing systemic disease activity in Sjogren. 190 patients with high systemic activity and symptomatic, very symptomatic, with the ESPRI 5 or more, and positive anti-SSA antibody were randomized into 4 arms, the placebo arm and 3 arms with increasing dosages of monthly subcutaneously ianalumab. The highest dosage, 300 milligrams, was significantly effective, as you can see on the left and also in the graph on the right, on the SDI score. While ianalumab was not effective on the symptoms, on the ESPRI. However, the stimulated salivary flow significantly increased over time. At week 52, the efficacy was also sustained for patients who continued 300 milligrams of ianalumab, while the efficacy was partially lost for those patients who switched to placebo at week 24. and a slight improvement was noted for placebo patients who switched to ianalumab at the dosage of 150 milligrams. The clinical efficacy was also supported by immunological efficacy on B-cell producing anti-SSA and anti-SSB antibodies. So overall, the drug was well tolerated up to 1 year of treatment without deaths. The highest exposure adjusted incidence rates of treatment emergent adverse events were seen for infections, and there was no dose dependency of treatment emergent adverse events except for local injection reactions. There were 3 cases of late onset neutropenia with no associated infections so far, and the B-cell recovery is similar to that recorded for other B-cell targeted therapies. Thus, the crucial message is combining B-cell depletion and BAFF inhibition could be effective in Sjögren's syndrome. Notably, it has been known for a long time that combining treatment that targets directly B cells and therapy that targets BAFF increases the depletion of B cell in the tissue, as demonstrated by Gong in 2005 in the mouse model. And recently, combining anti-CD20 therapy and belimumab has been applied with success in resistant cases of cryoglobulinemic vasculitis in Sjögren's syndrome, also in cases of Sjögren's syndrome, cryoglobulinemic vasculitis, including our first case reported in 2014. In this context, the preliminary data on phase 2 trial comparing placebo to belimumab and rituximab combination treatment, belimumab monotherapy and rituximab monotherapy show no differences among active arms. However, the best improvement was observed in the combination therapy, and the stimulated salivary flow showed a trend in favor of belimumab and rituximab in comparison with placebo over later time points. But very importantly, sub-analysis on B-cell biomarkers further showed the deepest and the most prolonged B-cell depletion, both in the blood and at the tissue level in the lip biopsy by the combination treatment with belimumab and rituximab. So, to conclude, quality of life and glandular manifestations still represent a challenge for clinicians involved in the treatment of Sjögren's syndrome, despite many treatments, included biologics tested in clinical trials so far. Systemic disease, systemic manifestations in Sjögren may probably need a combination of different mechanisms of action, and very recently, the preliminary success of the phase 2 trial with the ianalumab taught us that simultaneously targeting B-cell directly and indirectly may be effective in very active systemic disease, in particular on some clinical domains such as glandular, articular, cutaneous, lymphadenopathy, and biologic domains. Finally, since Sjögren's syndrome is a heterogeneous disease at the clinical level, the aim of further research is to improve patient profiling at biological and molecular level for best tailored treatment in each individual patient. Many thanks to my colleagues, my young colleagues involved at our clinics in the management of Sjögren's syndrome and also in Sjögren's syndrome research projects. My mentor, Professor De Vita, who strongly support our research in Sjögren's syndrome. And finally, my great friend, my great Egyptian friend, Professor Jafar, for this kind invitation. Thank you.
Thank you very much for this nice talk. It was very clear, and we could have an update of the major clinical symptoms and an up-to-date treatment for Sjögren's syndrome's treatment. Thank you very much. Are there some questions? Yes, please.
Thank you very much for informative and motivating talk. Many authors now consider Miculex as IgG4 related disease rather than Sjögren. Does it matter? Because is it because of the response to treatment when IgG4 respond to steroids marvelously? Again, the most serious association or complication of Sjögren is lymphoma. We do not see many patients with lymphoma, with Miculex, but with Sjögren. But the thing is, Sjögren is associated with some rheumatic, autoimmune rheumatic diseases, up to 30 to 40% of these patients. But for lymphoma, it's very rare. It doesn't matter if it is associated disease, it's okay. But if is it risk for lymphoma or lymphoproliferative disease, in this case, we need to monitor the patients for a very long time. Particularly when you say that in primary Sjögren, you use belimumab and rituximab, which is not easy. So we need to know if it is complication of the Sjögren or is it just association between them. Thank you.
Excuse me, your microphone is off. Please turn it on. Thank you.
Oh. My microphone is okay now.
Thank you.
Okay?
It's okay.
Okay, thank you. So this is a very important question. It's true that only a subgroup of patients with Sjögren develop over in their life lymphoma. But lymphoproliferation is demonstrated in the lip biopsy at diagnosis with the focus score 1 or more, and some other extragranular manifestation taught us that Sjögren's syndrome is a different autoimmune disease, different from other autoimmune diseases, such as tubular interstitial nephritis, and this manifestation is a lymphoproliferative manifestation, a lymphocytic infiltration of nephritis, more similar to IgG4 disease than the renal involvement, inflammatory involvement in other autoimmune disease, or for example, the interstitial pneumonia, the lymphocytic interstitial pneumonia. And so the point is, what's Sjögren? Sjögren is a lymphoproliferative disease from benign lymphoproliferation to over lymphoma, of course, associated with autoimmune disease. And the malt tissue is the origin of Sjögren in our mind. So target mild tissue is key, maybe key, also to prevent the dangerous evolution in lymphoma.
Thank you, Luca, for this presentation. I think we are short of time now, and we have to move to the third presentation. We are ready. We are online with Professor Jérôme Avouac. How are you, Jérôme?
Fine.
Let me introduce you, and then I leave you to your colleague to continue the introduction. Professor Jérôme Avouac is a senior rheumatologist in Cochin Hospital, professor Paris University. He is interested in developing medical approaches for personalized medicine for rheumatoid arthritis. He's leading the innovative projects of research on vascular as part of inflammatory rheumatic disorders, especially in rheumatoid arthritis, within the pathogenesis and innovative therapies in chronic fibroinflammatory diseases team at Cochin Institute. He's focusing on the preclinical evaluation of antifibrotic treatment, and especially in animal models, for the lung, for the skin. I think Alexis, Professor Jean can continue the introduction. You are most welcome, Professor Jérôme Avouac, and we are pleased to have you. It's really a privilege to have you to introduce us to the updates on scleroderma.
So, Jérôme, I'm pleased to introduce you as a colleague because we work in the same hospital. So you have been working for a long time on systemic sclerosis and rheumatoid arthritis. Specifically, in systemic sclerosis, you've worked with your European group and made huge work and important work on the disease. So thank you for your talk, and see you soon in Paris.
Thank you. Thank you very much, Alexis. Thank you very much, Gafa. Thank you for the kind invitation. I'm very sorry not being here with you only remotely, but still, I'm very pleased to do this talk on systemic sclerosis, and it's a pleasure to do this talk in 2022 because 10 years before, the pleasure will have been less important. Why? Because we have made major improvements in the care and treatment of systemic sclerosis these last years. So I think it's really important to do an update about what we know about the disease, about how we treat the disease. So the subject is perfectly fits with what is going on now in 2022. So first, some generalities about the disease, just to be sure that we are talking about the same thing. Systemic remains a very severe and heterogeneous disease. It's the most severe of connective tissue disorders with a highest rate of mortality. And the disease is very heterogeneous.
Just a quick stop. I don't know if it's, but you don't share your screen.
Oh. Oh, okay. I start again.
No, okay. It's okay. It's just we have different views than the audience. Okay, sorry.
Is that okay?
Excellent for us.
Good.
Okay, now the audience can see everything. Okay, you can go on. Sorry for the interruption.
No problem. It's better to have the good images and good slides. So just to show you the heterogeneity of the disease with the first panel on the where you see the vascular component of the disease that is prominent in systemic sclerosis, with first the Raynaud phenomenon, which involves all patients, and then turning into some complications like digital ulcers, necrosis, or gangrene, which are major problems for the care of patients. And you have also the fibrotic content in the disease with the skin fibrosis and with other some complications like calcinosis, for examples. And finally, you have organ involvements, and that will define the prognosis of the disease. And you have 3 examples. First, primary myocardial involvement, which is the third cause of death related to systemic sclerosis. Pulmonary hypertension, that's also the second cause of death in systemic sclerosis. And lastly, the first cause is pulmonary fibrosis. And fortunately, now we have new drug approaches of interstitial lung disease, pulmonary fibrosis, we will develop later. So when you think about therapeutic objective, the most important remains survival. Then, of course, you want to improve function and quality of life. And that's very interesting because when you ask patients what is important for them, finally, organ involvement is not so important in their view. In their view, what is important is the disease, is the pain, is the skin, the renal phenomenon, and the GI involvement. And these complications are not usually are not so can be severe, but they are very impairing patients' quality of life, but they are not responsible for death. But that's the main concern for the patients. But in the mind of the rheumatologist or the doctor, survival and the main organ involvement remains the most important things to assess in the disease. In the next slide, I hope it will appear for you. There is some lag, some time, because I see you're still in the last slide. I'm not sure that you're seeing the correct slide because I've moved, but in the screen, I'm not sure. Can you confirm that you see some
No, unfortunately, we are still at the same slide, Jerome.
Yes, that's my impression too. Because I'm moving the... That's a problem. Okay. I try again to share, but... So I can try to start to describe the slide, even if there is not appearing. I think it will be appearing in a few seconds. So one of the most important characteristics of this is the development of fibrosis. And fibrosis involves the skin and involves also internal organs. So for instance, you have images of skin dermis with a proliferation of the connective tissue and accumulation of extracellular matrix proteins like collagen or fibronectin. And the same is also involving the lung with fibrosis in the lung and fibrosis also in the vessels, in the myocardium, in the pulmonary vessels, or in the kidney. Here you have the slides. So in the myocardium and pulmonary vessels and kidney, what is important is the myointimal proliferation, reducing the caliber of the disease, causing insufficient vascularization and chronic hypoxia, what is one very important component of the disease, which are explaining primary myocardial involvement, pulmonary hypertension, and scleroderma renal crisis. Regarding the pathogenesis, so again, the slide is not moving. That's problematic because the next slide is very important because it shows you an overview of the pathogenesis of systemic sclerosis. And yes, so we are. So the pathogenesis is still complex. Probably we have not understood all the components and all the things very important of the pathogenesis. Nevertheless, we have made progress in this understanding. So the disease starts probably in the vessel, following genetic predisposition combined to environmental factors. And endothelial cells probably are the first cell involved in the disease, with activation of these cells leading to endothelial cell apoptosis and necrosis. This leads to the production of adhesion molecules, accumulation of platelets and recruitment of inflammatory cells that will cross the gap from the vessel to the interstitium. The connective tissue will invade the connective tissue and activate the immune cells. So following this endothelial cell activation, you have a very, very important event in the disease, that is immune activation. And immune activation will lead to the infiltration and recruitment of inflammatory cells in the connective tissue, in the interstitium. T cells are the major immune components that infiltrate the interstitium, but you have also macrophages, which has M2 phenotype, and also B cells that are very important because they can present the antigen, but they will also produce disease-specific autoantibodies, like, for instance, anti-topoisomerase antibodies or RNA pol 3 antibodies. And these cells, these immune cells, while they're activated, they will lead to the production of growth factors and cytokines that will activate the fibroblast. And the fibroblast, when it's activated, it will differentiate into myofibroblast, and myofibroblast has different contractile properties and will produce extracellular matrix proteins like collagen, fibronectin, and this production is totally unregulated, not controlled. And this leads to the skin fibrosis, the remodeling of microvessels, and also pulmonary fibrosis. So it's like a triangle starting with first vessels, then autoimmune activation, and all culminates to fibrosis. And another element that is important in this slide is the drugs that are available and then that can target the different cells. And we have made a lot of progress because 10 years ago, we used mainly immunosuppressive drugs trying to target only the immune phase of the disease. But we have developed treatments to target the vascular phase of the disease. And most importantly, now we have drugs that target also the fibrotic phase of the disease, targeting directly the fibroblast. And the best example is the development of nintedanib in interstitial lung disease that target directly the fibroblast. It can also target immune cells, but it's an anti-fibrotic drug that is able to block, to inhibit the differentiation from the fibroblast to the myofibroblast. So the pathogenesis is better and better understood, and we are now able to develop drugs that can target the different phases of the disease. So in the next slide, this is presented here the natural history of the disease, starting from on the left, undifferentiated connective tissue disorders, moving to early SSC with the appearing of fibrosis, with skin fibrosis, and the development of SSC to an advanced stage. And like we have observed in rheumatoid arthritis, there is probably a window of opportunity for the treatment in early patients. In these patients, there is a transition from inflammation to fibrosis, and when we target in the early phase inflammation, probably we can prevent the development of fibrosis. Of course, if you intervene too late in advanced stage, it's very complicated because fibrosis is already established, and it's almost impossible to go back when fibrosis is already here, even now if we have some treatments targeting fibrosis. So I will talk about interstitial lung disease because this is the part of the disease that known the best therapeutic development these last years. First, some words about the prevalence. It's frequent in systemic sclerosis. It's approximately 40% of patients who has interstitial lung disease. You have here this prevalence in different cohorts. And the most important cohort probably is the EGYSIR cohort with almost 15,000 patients. And you see here the prevalence of 38%. And when we do a meta-analysis of prevalence, we are close to 40% of prevalence of ILD. Chest CT scan is very, very important for the evaluation of ILD because it gives you first the information about the nature of the CT scan involvement, and the main pattern observed in chest CT scan is NSIP, non-specific interstitial pneumonitis, characterized by ground glass, reticulation, and bronchiectasia. This pattern is much more frequent than UIP, usual interstitial pneumonitis, that is much more fibrotic and it's rather observed in other connective tissue disorders, for instance, in rheumatoid arthritis. In systemic sclerosis, NSIP is the main pattern, but even if we observe more NSIP, which is more inflammatory, the prognosis of this pattern is not very, very good in systemic sclerosis. To define the prognosis of ILD, so we use GT stress CT scan. Very important to define the extension of the lesions. For instance, less than 20%, the disease is characterized as limited. More than 20%, the disease is extended with a worse prognosis. And when it's undetermined, you need pulmonary function test and the evaluation of FVC. When the FVC is decreased, less than 70%, it corresponds to extended disease, and FVC equal or more than 70%, the disease is considered as limited. And these elements are very important to define the prognosis, since limited disease has a much better prognosis than extended disease regarding mortality and survival of the patients. And another important feature that needs to be assessed in pulmonary fibrosis is oxygen saturation during the 6-minute walk test. When it's decreased less than 90%, that's also information about the severity of interstitial lung disease. So it's very important to consider HRCT, chest HRCT, pulmonary function test, and 6-minute walk test when to define the prognosis of the disease. There are some risk factors that has been previously identified for the progression of interstitial lung disease. Some are general, not SSC specific. For instance, the pattern, the usual interstitial pneumonitis pattern is with a worse prognosis than NSIP. The presence of bronchiectasis is also of bad prognosis, or if the disease is extended with rapid progression, or if there is no stabilization or regression after the first-line therapy. And of course, older age is also associated with worse prognosis. And there are some factors that are specific of systemic sclerosis. The older age at SSC onset is a bad prognosis, a short disease duration. The Afro-American patients are also of worse prognosis. It's not only for ILD, but also for other components of the disease. These patients are, for instance, are more likely to develop sclerodermal crisis or primary myocardial involvement. Gastroesophageal reflux is also of bad prognosis in ILD, and regarding antibody patterns, the presence of positive antitopoisomerase 1 antibody is also of bad prognosis. So it's important to consider all these factors when you intend to evaluate and treat a patient with ILD to define its prognosis, because in case of presence of bad prognosis or factors of bad prognosis, you may want to be more aggressive regarding the treatment. So there are some news regarding the treatments with authorization of different drugs in ILD associated with systemic sclerosis. First, nintedanib. We have some words before about the drug. Nintedanib was authorized in the US and also in Europe for the treatment of SSC-associated ILD. Tocilizumab. We discussed this drug with Alexi in giant cell arteries, but tocilizumab is also used in rheumatology in routine for rheumatoid arthritis, and now it's also authorized in systemic sclerosis for the treatment of ILD only in the US, but probably it will arrive in Europe in the next months. And finally, rituximab with the DESIRE study obtained an authorization in Japan for the treatment of SSC, not only ILD, but the treatment also of skin involvement and the general treatment of the disease. So regarding nintedanib, which is a very, very interesting drug, because that's a targeted therapy, not biological therapy, but a synthetic therapy, a small molecule tyrosine kinase inhibitor that targets the kinase active sites of the different receptors of growth factors, PDGF, FGF, and VEGF, which are key growth factors in the pathogenesis of systemic sclerosis. So blocking this kinase active site leads to the inhibition of downstream signaling of all this growth factor signaling. So it can inhibit the proliferation, migration, and transformation of fibroblasts. So it's anti-fibrotic therapy. And that's very, very interesting considering the fibrotic component of systemic sclerosis. This drug was previously used in fibrosis in other conditions, but there was a very important study named Census that led to the authorization of the drug in systemic sclerosis. And in addition to the antifibrotic, nintedanib is also able to inhibit inflammation and angiogenesis, which are also crucial steps in the pathogenesis of the disease. So nintedanib interferes with multiple pathological pathways in fibrosis, with blocking receptor activation, inhibition of M2 macrophage activation. M2 macrophage are very important for the activation of fibroblasts. Inhibition of immune stimulating and pro-fibrotic mediators like FGF or PDGF, and also inhibition of fibrocyte activity, and also this anti-angiogenesis by blocking, inhibiting endothelial cells activation. And finally, it blocks the production of extracellular matrix proteins. So the Census trial that led to the official authorization of nintedanib in SSc-ILD was the most important trial ever done in systemic sclerosis. It includes more than 500 patients. And these patients were randomized into groups. The randomization was quite simple. Patients received either nintedanib orally 150 milligram BID or placebo. And they were assessed at 52 weeks for the primary endpoint, which was the annual rate of LBC decline. You have presented here the key inclusion criteria. So the disease has to be less than 7 years disease duration. So it can include patients with already established systemic sclerosis. That is quite important because most of the trials usually target patients with very early disease, less than 3 years. So in this trial, it included patients with established disease more than 5 years of disease duration. Patients had to present to have developed pulmonary fibrosis with an extension of at least 10% on chest HRCT, performed less than 12 years before the screening. And the patients has to be not so severe, with FVC more than 40% predicted and DLCO between 30 and 89% predicted. You have also the key exclusion criteria. And very interestingly, background therapy was authorized in this trial, because usually with other drugs, and especially drugs that target the immune system, background therapy was not authorized. But in this study, prednisone was possible with a dose of less or equal than 10 milligrams per day, and patients can be treated with stable mycophenolate or methotrexate prior to randomization. You have here in this table presented the different baseline characteristics. So patients were well distributed into the two treatment groups. They were similar. Half of the patients had diffuse cutaneous systemic sclerosis. And it's very interesting because usually older trials restricted their inclusion criteria to diffuse cutaneous systemic sclerosis. And in this trial, patients with a limited cutaneous subset was also included. So the trial was very inclusive. The modified random skin score was about 10, so not so elevated. The mean disease duration was 3 years in the two groups. Main antibody subset was antitopoisomerase, and approximately half of patients were taking at baseline mycophenolate. So that's very interesting because we can evaluate, even if it was not the objective of the trial, but we can evaluate the combination therapies between nintedanib and mycophenolate, because this trial authorizes the possibility for patients to be treated with mycophenolate. And you have the characteristics Regarding the extent of fibrosis, more than 35%, so the extension was important. Remember, this was more than 20%. And you have the mean FBC in milliliter and percentage, so approximately 72% in both groups. So patients were with extensive disease and were close to the 70% that define also the severity. So the main results of the trial, so you have the annual rate of decline in FVC, and the first information is in the placebo. This liters. This is cleansing 90% pertinent patients as 52 milliplas significant. And in the right, I think, more interesting thing, the results, you have the decrease in the placebo group of the EBC over the 52 in group. Another interesting amount of my, so in the domain of lost and in group, patients were lost 66 million. See that there is a protective mycophenolate patients not placebo lost more NBC percentage than patients with placebo receiving mycophenolate. And interestingly, when patients received combination of nintedanib and mycophenolate, the decrease rate of FBC was less pronounced than the other groups, with a loss of 40 milliliters, compared to patients receiving only nintedanib without mycophenolate, where they lost 54 milliliters. So it suggests that there is a place for combination therapy, and it indirectly suggests, because the trial was not designed to show the superiority of the combination, so it's only indirect evidence, but it suggests that combination of mycophenolate and nintedanib is even more efficient than each drug taken in monotherapy. However, and that's the main issue of using nintedanib, that's the important frequency of side effects, especially digestive side effects, with important occurrence of diarrhea, 76% in nintedanib compared to 30% in placebo. Also, nausea was more frequent, and vomiting was also more frequent. And that's a very strong issue, I think, in systemic sclerosis, because CC patients displays GI involvement with high frequency of diarrhea, nausea, vomiting, and we increase the GI burden when we use nintedanib. And I think that can limit the use of this drug in systemic sclerosis compared to other diseases. Regarding tocilizumab, that is the second drug that received an authorization in the US. Tocilizumab, you know this drug because you use it in some connective tissue disorder, vasculitis, or rheumatoid arthritis. There was some rationale to use tocilizumab in systemic sclerosis because there was increased IL-6 expression in the skin or in the serum of SSC patients. And there was a phase 2 study that was very promising using tocilizumab in SSC. And I just present you the results of the phase 3 trial called FOCUS. It's a study performed in early diffuse systemic sclerosis, recruited 210 patients that were randomized either receiving tocilizumab or placebo. And so the main inclusion criteria and exclusion criteria are presented here. What is important to know is patients who had early disease, diffuse systemic sclerosis with signs of disease activity and inflammation. so to increase the possibility to respond to the drug. And unfortunately, also, of course, you have the disease characteristic of the patients, showing you that the duration was only 20 months approximately in the different groups. It's diffuse cutaneous systemic sclerosis with a total worldwide skin score of 20. It was 10 in the census trial. Here it's 20. And you have here the trial was not designed to show superiority of the drug for the lung. So it was designed for the skin involvement of the disease. So I just go back to the characteristic of patients, showing you that the FVC was almost 80% between the different therapeutic subgroup. So unfortunately, the trial was negative. Tocilizumab failed to show a significant difference regarding the primary outcome, which was the modified Rodnan skin score. Probably not linked to the drug, because the decrease of the modified Rodnan skin score was approximately 6 points in the tocilizumab treated patients. That's meaningful. But there was an important placebo effect, because in the placebo subgroup, patients lost almost 4 points of modified Rodnan skin score. So the difference was finally not significant and probably explained by high placebo effects in this study. But still, the more interesting results were obtained with secondary outcomes, which was the course of the FVC at week 48. And of course, it has to be taken very carefully, because that was not the primary outcome of the trial. It was a secondary outcome. But still, it's quite interesting to see in the whole population of patients in the two left panels to observe that patient in tocilizumab, the course of FVC was very stable. And conversely, in patients receiving placebo, there was a decrease of FVC. And when were assessed specifically patients with interstitial lung disease, it's two right panels, the results were completely superposable. You see here that there was a stabilization of FVC in patients receiving tocilizumab and a decrease in patients receiving a placebo, even in the subset of patients with interstitial lung disease. And there was some evaluation of CT scan, and it was either pre-specified or a post-hoc analysis. But interestingly, when they looked to the quantitative interstitial lung disease in the lobe was most involvement or in the whole lung, there was an improvement of the densities detected with HRCT, and it was significant for all the endpoints. So an improvement of the HRCT following tocilizumab treatment in patients presenting interstitial lung disease, either fibrosis, but also global interstitial lung disease. And finally, the last drug is rituximab. Some words about the EGYSIR trial conducted in Japan, which was randomized controlled trial of rituximab versus placebo, which included patients with systemic sclerosis with MRSS equal or more than 10, with no corticosteroids to more than 10 milligrams per day, and no immunosuppressive within 4 weeks, or no antifibrotic agents, so only rituximab. We have also the key exclusion criteria that are presented. So patients asked to be not so severe with FVC less than 60%, which was considered as an exclusion criteria. So the first endpoint was the skin with the absolute change of the MRSS at 24 weeks after starting rituximab. And you have also presented here the key secondary endpoints, especially the lung endpoints with the absolute change of percentage FVC in patients with ILD. So one limitation of this trial is probably its sample size, which was not so important. 28 patients in each subgroups. Patients were 49 years old. Majority had diffuse cutaneous involvements. The disease duration was 58 months in rituximab, 52 months in the placebo subgroup, and the modified Rodnan skin score was approximately 15 in both groups. and you have the characteristic of ILD with the different volumes. You see that they used KIL6, which is a marker, a biomarker of fibrosis, not used in routine in Europe, but used in routine in Japan. And also the extension of fibrosis, which was approximately 13 to 15%. And half of the patients had antitopoisomerase 1 antibodies. So the main results for the first endpoint, the primary endpoint, was the efficacy of rituximab to treat, to improve the modified Wolinski score at week 24. You see the curves are different of the focus trial with tocilizumab, because there was a decrease of MRSS in the rituximab subgroup of 6 points, very similar to what was observed with tocilizumab. But the main difference between two trials was in the group placebo, because in the group placebo here, the patients did not worsen, the MRSS did not decrease in the placebo subgroup as we observed in the tocilizumab trial. In the DEGYSIR trial, the MRSS were even stable or even slightly increased. So finally, the difference was very statistical significance because here there was no placebo effects as we observed, contrary to what we observed in the tocilizumab trial. Regarding the FVC percentage patient with ILD, the result was also significant at week 24, in which there was a deterioration of FVC in the placebo group compared to a less important degradation, and even an improvement of FVC at week 24 in the rituximab subgroup. And I mentioned here the different secondary endpoints of interest, which one of them was different in the rituximab compared to the placebo. It was the change of FVC at week 24, as presented in the last figure. And the safety was good of rituximab. There was no safety signal, no new safety signals recorded. This was the same for tocilizumab. But we have to keep in mind that using rituximab in a COVID period is still difficult because there was more severe COVID-19 described in patients treated with rituximab, especially patients with interstitial lung disease, and also the consequences of rituximab on the vaccination for COVID, in which humoral response is decreased, very, very importantly decreased in patients receiving rituximab. So this has to be considered in a COVID period when you want to treat your patients. So following these authorizations and these positive results of these drugs to treat SSc-ILD, some algorithms were developed to manage patients with SSc-ILD. So this was an example. That's not the only one. There is still efforts to construct new algorithms to help clinicians for managing these patients. And you have here the possibility in this algorithm not to treat patients if there is no interstitial disease, or if the disease is only limited without any risk factor for progression. But you have to treat your patients if you have extensive disease or limited disease with factor of bad prognosis. And you can treat either with monotherapy or combination therapy in case of very aggressive disease. And if depending of inflammation on CT scan, you can choose, for instance, mycophenolate, or if there is more fibrosis, using nintedanib, and then combine therapy in case of risk of bad prognosis or in case of absence of response with a monotherapy. And in this algorithm, rituximab and tocilizumab were used as the third-line drugs after failure of nintedanib and mycophenolate mofetil. And some reflection here are presented here for the therapeutic management. So we have at our disposal drugs targeting inflammation and or fibrosis. So is it better to consider MMF, tocilizumab, or rituximab in patients with recent disease, with inflammation on CT scan, with the NSIP pattern? For instance, if there is some other articular involvement, we know that rituximab, tocilizumab are very efficient. And in case of systemic inflammation with higher levels of CRP, presence of tendon friction rubs, tocilizumab may be a preferred option. And for nintedanib, maybe it's interesting to consider this drug in patients with more established disease, because we've seen that in the Sensis trial, patients had sometimes more than 5 to 7 years of disease duration, reduced inflammatory components with a more prominent fibrosis, and for instance, with a UIP pattern, which is characterized like the image here by a huge fibrosis. I will give you some words about other complications of systemic sclerosis. Pulmonary hypertension. First, there was some modification of the definition of pulmonary hypertension, and I think it's really important to know these modifications. That now the classification of group 1 pH or isolated precapillary pH is defined with a mean pulmonary artery pressure of more than 20 milligram of mercury, and with a pulmonary capillary wedge pressure less than 15. And that's the novelty of the definition. The pulmonary vascular resistance is now considered, and it needs to be more than 3 Wood units. And you have here the combined pre- and post-capillary pH and isolated post-capillary pH associated with pulmonary wedge pressure more than 15 and the pulmonary vascular resistance less than 3. So recent meta-analysis has shown a stability of pH prevalence among time of about 10% of patients, and with meta-regression analysis, we have seen, you see that this prevalence did not change, so there was no decrease or increase of pH prevalence. But interestingly, what this meta-analysis shown was a better short-term prognosis of pH among time. You see the distribution here of the trial with short-term mortality at 1 year, and you see that this mortality at 1 year is decreasing between 2000 to year 2015, sorry. So an improvement of short-term survival. Unfortunately, it was not confirmed for longer-term survival at 3 or 5 years. But why this short-term survival has been improved? Probably because we know better how to characterize pH with the use of systematic use of right heart catheterization that can identify clearly PEH associated with arterial remodeling. Also identify precapillary pH associated with pulmonary fibrosis. And of course, the prognosis of this group 3 pH is very, very bad, but we know how to manage using some drugs and oxygen, for instance, and also identify left heart disease with diastolic dysfunction responsible for pulmonary venous hypertension, in which the treatment is different. So better knowledge of the different type of different etiologies of pH, leading to a better care of patients. And we are less deleterious because now we know how to identify these different subsets of pH. And the second explanation, in my opinion, that explains why the prognosis, short-term prognosis is better. That's now, it was based on the Ambition trials, the combination therapy between combination of ambrisentan and tadalafil, and combination therapy have shown better results compared to monotherapy. And we use more and more this combination. And the Ambition trial was very interesting because many of patients had a CTD etiology, and systemic sclerosis was 63%, represents 63% of the CTD etiology in this Ambition trial. And in the CTD and in the SSC, the results were the same. So a better outcome in patients receiving the combination therapy compared to the monotherapy in terms of death, in terms of worsening, of hospitalization for worsening, disease progression. So patients receiving the combination, their outcome were significantly better than patients receiving monotherapy. So better identification of the cause of pulmonary hypertension and a stronger, more aggressive combination therapy, in my opinion, explain the better survival of a patient with PEH, at least a better short-term survival. Regarding other vascular complications, digital ulcers and scleroderma renal crisis, there are not so much updates. I think it's interesting and it really reflects what we observe in clinical practice, that patients, the prevalence of ulcers tends to decrease among time. It was illustrated by this meta-analysis. I have no clear idea why we see less digital ulcers, and whereas the prevalence of PH remains stable among time. Maybe someone will say there is a global warming and that can explain why we see less patients, but maybe because we are taking care of this complication, I think, more efficiently than before. And we know how to recognize now very well the mechanism of digital ulcers. Is it ischemic or mechanical or related to calcinosis? And we are still more aware of the criteria leading to active digital ulcers with a pain and loss of substance, leading to earlier referral of this patient in hospitalization for specific treatments. And probably we know how to manage complication of ulcers. And even if a patient with multiple ulcers or with infection or necrosis are still difficult to treat now. And so there is some important inputs regarding the treatments. The local treatment is very important when we want to treat digital ulcers to ensure the healing and prevent complication like infections with the detersion, wound cleaning, and use the correct hydrogel or hydrocolloids for the patient. So that's very I want to give a really important emphasis of the importance of the local treatment in digital ulcers together with drug therapy. And there is no novelty regarding the drug therapy of digital ulcers. We still continue to use procyclin infusions to relieve pain very quickly and stimulate the healing process. Sildenafil could be also interesting in case of prostacyclin insufficient efficacy. And we still have the possibility to use bosentan for the prevention and not the cure, but for the prevention of recurrent DU. And finally, regarding scleroderma renal crisis, I think it reflects the fact that we, take care more efficiently of vascular complication of the disease. We observe reduced prevalence of scleroderma renal crisis among time, and also short-term mortality and the dialysis, the percentage of patients requiring dialysis during SRC is also improving within time. And of course, it's related to the large use, curative use of ACE inhibitors that showed in a long time ago that they were efficient, but clearly it has changed dramatically the prognosis of this complication. So to conclude, the important messages of this talk, please remind that SSC is a heterogeneous disease characterized by major organ involvements leading to increased mortality. There are very important new therapeutic use in ILD, and with potential interesting perspective like the quantitative evaluation of HCT using artificial intelligence that is under development and that will help us to better stratify the treatment of our patients, and also the identification of progressive ILD combining chest HRCT and pulmonary function test as we previously discussed. There are new registered medications, very importantly in nintedanib, but also tocilizumab and rituximab. And what we need now is to design algorithms to improve the management of this condition because now we have at our disposal effective drugs. Regarding PH, improvement of short-term prognosis, that is related to a better comprehension of the mechanisms of pulmonary hypertension and early aggressive strategy. And regarding other vascular complications, decreased incidence of DU within time, importance of local treatments, and RCC, we have a proof now of decreased short-term mortality with the use of ACE inhibitors. So I thank you very much for your attention, and I'm ready to answer your questions. Thank you.
Thank you very much, Professor Abouak. And sorry about the bad transmission. I think we are entitled to 5 minutes more since the fourth presentation is totally recorded, and we have a break following the fourth presentation. I will take the advantage of being the chairperson to ask you two questions. The first one is about on the safety and efficacy, and if there is ever some reference to the combined use of rituximab and nintedanib.
That's a good question, very good question. For the moment, there is no clear evidence of combination therapy between rituximab and nintedanib or tocilizumab and nintedanib. We discuss a lot these combinations in what we call RCP. So when we discuss very difficult to treat cases of interstitial lung disease associated with systemic sclerosis. So these combinations are possible. So to combine a drug targeting immunity or inflammation, like tocilizumab, mycophenolate, or tocilizumab, mycophenolate, or rituximab, together with an antifibrotic drug. So I think that's the future. We need, I think, to better evaluate the safety of these combinations, particularly regarding the risk of infection, because infection is one trigger of ILD progression, and that's so it's important to take this into consideration. But the problem is that we have no real evidence of the efficacy of this combination, but we start in clinical practice to use them in severe patients.
Okay, thank you. The second question is on the digital ulcers. We have a good experience with autonomic ganglion ablation, whether by injection or thermoablation or whatever. What's your point of view on this? We have seen good results.
Which intervention?
I mean the autonomic ganglion ablation or injection or whatever.
I have no personal experience with this strategy. You're right that there is some case report in this literature showing that it can be effective. So of course, it can be considered. Unfortunately, now in our center we have not so much experience with this intervention.
Okay, thank you. We have time for just two short questions. First question, please.
Thank you very much. Interesting talk. The previous presentation was about Sjogren disease. And we know that Sjogren is associated with scleroderma, whether the crest, the limited, or the diffuse. In this case, associated crest or diffuse would affect the incidence and the severity and the progress of interstitial pulmonary fibrosis, or it doesn't affect. And in this case, if it is, what drugs of what you have mentioned of all these many drugs to use in this case? Thank you.
Thank you. That's a very interesting question of polyautoimmunity and combination of autoimmune disease. And as you mentioned, you're right. Approximately 15% of scleroderma patients has an associated Sjogren syndrome. And what is very interesting is when patients who has polyautoimmunity or combination of Sjogren and systemic sclerosis has usually a mild disease. The phenotype of patients with Sjogren syndrome is usually a patient with limited cutaneous systemic sclerosis with positive anti-centromere antibodies. And this subset of the disease is less associated with interstitial lung disease and complications, and fibrotic complication. So I have to say that patients who have this combination, usually interstitial lung disease is not a big problem. And these patients present digital ulcers, sometimes GI symptoms, which accumulate with the Zika syndrome secondary to the Sjogren syndrome, but less systemic complication than patients without Sjogren syndrome.
Thank you. Shortly, please, Dr.
Yes.
Ghali Abdel Mohsen.
Thank you very much for this presentation. You showed us in the clinical trial the effect of rituximab and tocilizumab on the skin score of the patients. Would you recommend to use this drug early in the disease? We all know how much the skin is devastating and makes a psychological burden for patients with scleroderma. Would you recommend these drugs in early scleroderma or to save it for the complications? Thank you.
That's a very, very good question, and you're perfectly right. And moreover, the skin is a surrogate of the disease. If the skin is worsening, the whole disease is worsening. And you're right that these two drugs target the immune system, and the role of the immune system is prominent in the early phases of the disease. So if you want to choose a treatment like rituximab or tocilizumab, it's better to use it at the early phase of the disease during the transition between inflammation and fibrosis. So yes, I would recommend to use these drugs in case of failure of methotrexate, for instance, of mycophenolate mofetil, and we have very, very excellent results with rituximab for the skin involvement when it's used in early phase of the disease. When you wait too much, the results are more disappointing. And tocilizumab, regarding the skin, the results are very, very heterogeneous. And in some patients, it works very well, in others, not. So we need more data to clearly envisage the use of tocilizumab for skin involvement, in my opinion. It's better to use tocilizumab in case of ILD because we have evidence of efficacy in this complication.
Thank you.
Thank you very much, Professor Avouak, and hope to see you in person next year.
With pleasure. Thank you very much.
Thank you. Now we move to the fourth presentation. It's all recorded and there is no online interaction. So Professor Ashutosh Vaishali is a professor of medicine and hematology at the University College of London and honorary consultant hematologist at its hospital and the Royal Free Hospital, UK. His work is focused on amyloidosis with a particular focus on early detection of all types. He leads the AL program for the UK. He's the director of the Jack O'Neill Amyloidosis Laboratory focused on typing and genomics for the disease. And he leads the UK's first dedicated amyloidosis treatment clinic at the University College of London and leads development of the UK National Amyloidosis Treatment Network. And he leads AL amyloidosis treatment and research in the UK plus with extensive publications in the international literature. We'll be listening now and watching his presentation, and he excused that he had some obligations that will make him not available for interaction. Perhaps we can manage to do that at the end of the review course, but we are still waiting for his feedback. Please proceed.
Hello, good afternoon. Thank you for inviting me to this meeting to talk about amyloidosis, what the rheumatologists need to know. I'm sorry I'm doing this remotely and not in person, and I hope I get to see your beautiful country city and meet all of you in person in due course. Amyloidosis, as you all realize, is a disease of protein misfolding, where different proteins will adopt a common fibrillar conformation, as you can see here, bind with various glycosaminoglycans, oligomers, eventually to form amyloid fibrils. The primary process is an unstable protein, and one can have different unstable proteins, essentially ending up with the same fibrillary point of amyloid deposits. The three common types, AA amyloidosis, light chain amyloidosis, and transthyretin amyloidosis, are shown here on the slide. It's a difficult diagnosis. Lots of patients are not diagnosed very early. And that's because patients have very vague symptoms, fatigue, edema on their feet, maybe a trace of proteinuria. And amyloidosis is not suspected as the primary pathology causing this problem. This is a study which showed that patients on an average had visited at least 4 physicians before a diagnosis was made. The commonest physicians who make the diagnosis of amyloidosis are nephrologists, cardiologists, and hematologists. Patients from rheumatologists are often diagnosed with amyloid either in the care of the rheumatologists or when they're referred to one of these other corresponding specialties. Amyloidosis can be classified by a number of different ways, but the common ways of classifying it are either systemic amyloidosis or localized amyloidosis. Systemic amyloidosis affects many different organs. Localized amyloidosis will affect one single site. As rheumatologists, you're unlikely to come across localized amyloidosis. Systemic amyloidosis will typically affect the vital organs, heart, liver, kidney, nerves are the common organs affected, and could be of different types. Could be hereditary because of a mutation in a protein which predisposes somebody to amyloid, or because there is an acquired protein which is amyloidogenic, which is at a high level, or normal proteins which are persistently at high level or very high levels, such as in AA amyloidosis that you're interested in, or wild-type transthyretin amyloidosis that happens in the elderly, or B2 microglobulin-related amyloidosis. The presentation of amyloidosis can often give you clues about what may be the cause of amyloidosis, but this is not often straightforward, not often easy. AL amyloidosis can affect any organ. That's the most variable, most tricky to diagnose. There are some amyloidoses which typically present with renal involvement. And for me, they are AA amyloidosis secondary to inflammation. This is the one that you see. Hereditary fibrinogen amyloidosis, and then LECT2 amyloidosis, which is a new acquired type of amyloidosis that is quite common in patients from India, from Brazil, from Mexico, and also from Egypt. We don't really understand the pathogenesis of this type of amyloidosis, but I'll share a few slides about this later. Transthyretin apolipoprotein amyloid can affect the heart and the nerves, may occasionally affect the kidneys, as does lysozyme. These are more rare types of amyloidoses. And of course, then you've got the wild type transthyretin amyloidosis, which affects the heart, which is one of the common types of amyloidosis. We published this a couple of years ago, showing the change in the demographics of amyloid patients that were coming to our center. And as you can see, in the 90s and in the 2000s, AA amyloidosis accounted for about 50% of our workload. As years have gone by, the proportion of patients with AA amyloidosis has progressively gone down, and the proportion of patients with AL amyloidosis and ATTR amyloidosis have progressively gone up. We look at this in a different way. This is our current kind of assessment of patients with amyloidosis until 2020. We still see AL amyloidosis and localized AL amyloidosis as the two most common types. Secondary amyloidosis or AA amyloidosis now accounts for 8% of all the patients we see in our center. But we are starting to see more of ALECT2 amyloidosis, which is about 1 or 2% of all patients, and 10% of our patients still remain with hereditary amyloidosis. AL amyloidosis, which is one of the common types of amyloidosis, has multi-organ involvement, cardiac, renal, but also very peculiar soft tissue involvement with enlargement of the tongue, such as macroglossia, periorbital purpura. They get dystrophy of their nails, and of course, they will have hepatic and cardiac involvement. Heart and kidney are the two common organs involved in AL amyloidosis. The second type of amyloidosis, which is quite common, is wild-type transthyretin amyloidosis. This is being increasingly diagnosed in the elderly population by our cardiology colleagues, particularly with advent of cardiac MRI scan and bone scintigraphy, which is very helpful in diagnosing this type of amyloid. Patients typically present with a history of restrictive cardiomyopathy, a thick-walled heart with heart failure, often on the background of hypertension and diabetes, and they have carpal tunnel syndrome. That's a characteristic association. A patient with heart failure and carpal tunnel syndrome, amyloidosis then becomes strongly suspected as a possible diagnosis. There are a number of flags for transthyretin amyloidosis. You can have the heart and the carpal tunnel syndromes, as I said, but then patients who have hereditary transthyretin amyloid can present with autonomic neuropathy, such as orthostatic hypotension, sometimes ocular manifestations, gut loss, satiety, and signs of peripheral neuropathy. Cardiac involvement is very typical. If you do an echocardiogram in an amyloid patient, you can see that there is differential affection of the heart. The apex of the heart is spared, the base of the heart is affected more. And when this happens, you get, when we look at 2D longitudinal strain, so what's my approach to a suspected patient with amyloidosis in 2022? I think the key is this AL amyloidosis or not? AL isn't a medical emergency. These are patients with rapidly progressive amyloid disease who require urgent assessment and intervention, and a high proportion will die if not treated early. So my first step is monoclonal protein studies: serum protein electrophoresis, urine protein electrophoresis and immunofixation, and serum free light chain measurement. If these are negative, AL amyloidosis is unlikely, as less than 1% of patients with AL amyloidosis will lack a monoclonal protein in the serum or urine. Then it comes down to what organ is affected. Of course, the background history may give you clues. For example, as rheumatologists, if you have a patient with long-standing rheumatoid and renal involvement, AA amyloidosis goes high on your list of differential diagnosis. But if that wasn't the case, and if the patient came to you directly with a suspicion of amyloid, then we are working out, is it isolated heart involvement? If that's the case, we start thinking in terms of wild-type TTR amyloid, particularly in patients aged over 70, 75 onwards. On the other hand, if it is renal involvement or hepatic involvement or neuropathic involvement, then we are indeed into the other amyloid types. And of course, you have to then do a biopsy to type the amyloid deposits. If it is AL, patients will require a biopsy, detailed assessment of organ function with the planning for staging, and then moving on to management. We know very clearly from various studies, this is in AL amyloidosis with heart involvement with cardiac MRI scan. The normal heart should look black like this one. As amyloid deposits start to occur, you can see hints of white, a bit more white, and then the heart is completely turned white with lots of amyloid in their hearts. Patients who've got AL amyloidosis with their heart, the more amyloid they have, the worse they do. And that's true with every amyloid type. Even in AA amyloidosis, if you diagnose it early, kidney function reverses essentially back to normal. If you diagnose it late, it's often challenging. Since amyloidosis presents with rather specific signs and symptoms, and they're often very repetitive in their own way, but very challenging because they're very common, it lends itself to machine learning. A number of different centers around the world are now trying to attempt various machine learning algorithms to see if they can raise suspicion of amyloidosis in patients presenting with a variety of different problems. Variety of different features have been used. But the clue still remains. When you suspect amyloid, you have to do a tissue biopsy in vast majority of the cases. What do you biopsy? The organ that's affected is the most likely to give you the positive results. So if you have a patient who presents with proteinuria, kidney biopsy is more likely to give you the answer than any other biopsy. In AL amyloidosis, abdominal fat biopsy done properly can be positive in 80 to 90% of the cases. However, in patients with other types of amyloidosis, the rate of positivity may vary between 50 and 15%. Once you've done the abdominal fat, we can either do an immediate stain by doing these abdominal fat droplets, crushed in the slide and staining them in Congo red, or you can embed them in agarose gel, and then what you can do is section them as normal histology sections, and then you're able to stain them with Congo red and also use the fat for immunohistochemistry. A combination of abdominal fat and bone marrow gives the diagnosis in AL amyloidosis in 82% of the cases. In AA amyloidosis, about 50% of us will show positivity on an abdominal fat biopsy. The gold standard still remains old-fashioned Congo red staining. The methods by Pushler et al. Is the one, and we still find that it is the best method in terms of giving high positive rates and low false negative rates. Once you've shown that there is Congo red stain, you get the typical eosinophilic appearance on light microscopy and the classic birefringence on polarized light microscopy. You go on to do typing, which is typically with immunohistochemistry, direct fibril sequencing, or other methods. In AA amyloidosis, which is of course of interest to you, the amyloid presents with typically very bright combophilia. It's very bright, refringent under polarized light microscopy to the point where you can suspect it as soon as you see a brilliantly shining bit of amyloid under the cross-polarized light. Monoclonal antibody to AA are available, and they will give positive results with very clean and neat staining. It's important to remember that with the commercial antibody, there is a small false positive rate, and if your patient does not have an inflammatory disorder, please do think very carefully. There is another type of amyloidosis which is becoming increasingly common. We think it's the second most common acquired kind of amyloidosis in the world, particularly as with control of inflammation, AA amyloidosis is becoming less common. And this is known as ALECT2 amyloidosis. It's typically seen in populations from India, Mexico, and the Middle East. Presents with renal involvement, typically not very proteinuric chronic kidney disease, and sometimes with liver involvement. The Congo red stain shows this kind of very small granular sparkly deposits, and there is antibody available commercially for ALECT2, and it's very reliable on immunohistochemistry to diagnose LECT2 amyloidosis. 10% of all our patients still have hereditary amyloidosis. So even if a patient presents with renal involvement, it doesn't necessarily mean that they've got AA amyloidosis, even if they have a history. And we have to think of familial amyloidosis. And for this, we'll either require immunohistochemistry, or you have to have gene sequencing based on the combination of symptoms. These are patients with either renal or a combination of neuropathy and autonomic dysfunction, or two or more organs which do not fit the pattern, particularly when there is no monoclonal protein. The key problem is that the family history is variable, the phenotype can change, patients may have a gammopathy, immunohistochemistry is challenging, and there are multiple of novel mutations. We maintain a database, hereditaryamyloidosis.com, and you're welcome to have a look at this database, which lists all the mutations of known hereditary amyloidoses. The confirmatory amyloid typing is now by proteomics. You can do Congo red staining, you can put the slide under a laser capture microscope, you can cut out the amyloid deposits, and then you can subject them to tryptic digestion and mass spectrometry. With mass spectrometry, you can then compare it with the proteins reference database, which gives you the amyloid type, and that is now the gold standard for amyloid typing. I don't know if you've got access to immunohistochemistry or with mass spectrometry in Egypt, but certainly there are a number of reference laboratories that will receive your sample and give an answer. We do that for a number of cases. The Mayo Clinic Laboratories is also a good place to send samples to. AA amyloidosis is the one you are interested in. Amyloidosis secondary to inflammatory condition, chronic inflammatory conditions. It is the type of amyloidosis that is commonly seen in rheumatoid diseases. Rheumatoid arthritis remains the main and the commonest reason for AA amyloidosis, but is becoming increasingly uncommon as biologics are being frequently used. AA amyloidosis is a renal disease to my mind. All patients, almost all patients, will present with proteinuria, nephrotic range proteinuria, and renal involvement. If somebody comes to you with a suspicion of AA amyloidosis with normal kidneys and no proteinuria, please suspect there is some other kind of amyloid. Without renal involvement, AA amyloidosis is exceptionally rare. It can affect other organs such as the liver, the spleen, the renal glands, the gut, and very rarely the heart if inflammation remains uncontrolled for a very long period of time. The precursor protein for AA amyloid fibrils is serum amyloid A. It's a marker of inflammation. It's a component of the acute phase response. It's a high-density lipoprotein, and it behaves in a very similar way to C-reactive protein when you get inflammatory stimulus. Its gene is on chromosome 11. There are three different isotypes of SAA. SAA is synthesized by hepatocytes. We believe it is interleukin-6 dependent to a big degree and driven by other pro-inflammatory cytokines. As the inflammation subsides, just as the CRP level will come back to normal, the AA level will also return back to normal. This is a graph which shows the correlation between SAA and CRP. And in general, there is a good correlation, but as you can see, the line is skewed more towards SAA. SAA levels often tend to be much higher for the same degree of CRP. For example, you can see here, this patient had an SAA of 100, but the CRP was only 25. Patients here had an SAA of 4 or 500, but the CRP remained 50. So measuring both SAA and CRP are important in AA amyloidosis, as that is the driver of the disease. The incidence of AA amyloidosis remains unclear because a lot of patients are from a number of countries where epidemiologic studies are difficult. It is estimated that maybe up to 10 to 20% of patients with chronic inflammation may have amyloid disease on postmortem, but very few have clinically overt amyloid disease. In the United States, in Northern Europe, AA amyloidosis is becoming much less common. Reasons are unclear. Maybe infections in childhood are falling, chronic inflammatory diseases and chronic infections are less common. and we are treating inflammatory conditions with biologic therapies very early. Overall, the incidence of AA is dropping. Some people think there may be an environmental factor, there may be better sanitation, there may be better treatment of major cause of inflammation, including infections, and AA is therefore becoming a disease which is less common. There is also other risk for AA amyloidosis, which is SAA genotype. There are three main alleles of SAA, SAA 1.1, 1.2, and 1.5. There's a slightly higher transcription rate with SAA 1 and 1. There may be a number of cellular factors which are not very clear, such as apparent degradation of SAA by mononuclear cells. And then it seems to be more common in areas of birth, around some areas where there are other patients with AA amyloidosis. And one wonders whether there are some genetic factors which predispose families to have more AA amyloidosis than other families, particularly when there are hereditary diseases such as familial Mediterranean fever. The list of conditions underlying AA amyloidosis is very long. The first part of the list is chronic infections of all kinds. The common ones we see these days are osteomyelitis and bronchiectasis. Tuberculosis, certainly in the UK, is very uncommon. We often see patients with paraplegia and urinary sepsis. And the type we are seeing a lot of the times are patients who are coming intravenous drug use. Is another big cause of AA amyloidosis for patients who present with drug abuse or with subcutaneous skin popping drug injections. The area of your interest is, of course, the chronic inflammatory rheumatological conditions, all of the rheumatic diseases, rheumatoid arthritis, seronegative spondyloarthropathy, juvenile idiopathic arthritis, mixed connective tissue disorders, and even chronic severe gout. Acute vasculitis can cause AA amyloidosis, but is less common. We can see it with polymyalgia and giant cell arthritis, and often with Behçet's disease, very rarely with Takayasu, although it has been reported. Hidradenitis suppurativa is another condition that we see with AA amyloidosis. With the gut diseases, all kinds of inflammatory gut diseases can cause AA amyloid, but Crohn's disease seems to be more common than ulcerative colitis. We can see it with sarcoidosis, and quite interestingly, obesity, as you all know, is a pro-inflammatory condition in its own right. And we can see AA amyloidosis in patients who are obese but have no other inflammatory cause. The other big group of diseases where we get AA amyloidosis are the autoinflammatory conditions, the commonest being familial Mediterranean fever with mutations in MEF3 gene. This may be more common around the Mediterranean, and we certainly have a number of patients from Egypt with familial Mediterranean fever. Cryopyrin-associated periodic fever syndromes is another common type of amyloid, but this is, of course, rare. Will present with very severe inflammation, joint affection, and skin rashes. TRAPS and hyper-IgD syndrome are other rare autoinflammatory diseases causing AA amyloidosis. We can see AA amyloidosis with hematologic malignancies, particularly with patients with non-Hodgkin's lymphoma, where there may be an inflammatory phenotype, with solid tumors such as renal cell carcinoma, where patients can present with AA amyloidosis many years later. One of the key things with AA amyloidosis is to remember that your patient may have burnt out inflammation. 10 years later, they may get a really bad episode of chest infection, pneumonia, which lasts for a long period of time and present with AA amyloid. You only need a small amount of seeding fibrils for patients to present with AA amyloidosis years later. Same is true for patients with AA where the disease has regressed. As you can see, the age distribution of AA amyloidosis is very wide, but the commonest is between 40 to 70 years of age. And now increasingly seeing elderly patients with AA amyloidosis, often without a clear underlying inflammatory condition identified. But this other graph is quite interesting. Patients may have an inflammatory condition as long out as 40 to 50 years before AA amyloidosis was diagnosed, and it is very much possible that they laid some AA amyloid deposits at the time their inflammatory condition was there, and then present with a secondary inflammatory condition many, many years later. So although patient may not have an active inflammatory condition, it does not necessarily mean that they won't get AA amyloidosis. The aim of treatment of AA amyloidosis is very similar to every other kind of amyloidosis. Reduce the supply of the precursor protein. If you reduce the supply of SAA, that is, you turn off the inflammatory response, there is no amyloid precursor protein, amyloid deposits will stabilize and usually improve. Supportive care is critical to all patients. These patients are often very nephrotic, so you have to manage their blood pressure, make sure you preserve their intravascular volume, avoid any additional insults such as drugs, surgery, and unrelated sepsis, chest infections need to be treated very aggressively. Of course, we'll talk a little bit about how we can try and clear the amyloid deposits. This was work from Helen Lackman from our group, published many years ago, which shows that in AA amyloidosis, the relative risk of death continues to drop the lower your inflammatory control. If SAA levels are below 10, generally patients will do well. But if we can drop the SAA levels below 5, patients will do even better. There are a number of factors which predict mortality. Older patients do worse. Patients with periodic fever syndromes do worse. Patients with higher SAA do worse. Patients who are on dialysis do worse. And patients who show amyloid regression after treatment do better. Median survival now is definitely over 10 years. But for patients with controlled inflammation, they will indeed do extremely well. We also showed very well that when you track the median SAA level, patients whose median SAA level was below 10, majority of the patients showed regression of their amyloid deposits. Those with SAA levels of 20, we generally saw stability, and those with higher levels of SAA, there was worsening of organ function. Similarly, patients with low SAA, there was general improvement in renal function, whereas patients who had higher SAA showed worsening renal function and worsening amyloid load and SAP scintigraphy. How do you treat AA amyloidosis? The simple reason is you treat that inflammatory condition. If it's an inflammatory arthritis, then you would use disease-modifying agents. We would use biologic agents such as anti-TNF and IL-6. And alkylating agents were used, but are now used much less. For chronic sepsis, early prolonged antibiotic therapy, try and remove the inflammatory focus if possible. Patient autoinflammatory diseases, of course, colchicine still remains the best treatment for familial Mediterranean fever. If patients don't tolerate colchicine initially, it's worth trying to persuade them that this drug will change their natural history and they should try and persist with it. For the autoinflammatory condition, biologic therapies, particularly anti-IL-6 therapies, have a big role. Both IL-1 and IL-6, anakinra, as well as canakinumab, have a big role in treatment of this condition. Crohn's disease, steroids and immunosuppressives. If SAA levels are not normal, move on to biologics. Unicentric Castleman's disease surgery is very good. Anti-IL-6 treatment with anakinra is very effective. In obese patients, we have shown that bariatric surgery with marked weight loss can have a big role. And then in cystic fibrosis, of course, these patients have chronic pulmonary sepsis, bronchosepsis, and will require appropriate therapy. I'm just going to touch briefly on AL amyloidosis. We've got a number of new and exciting therapies coming along for AL amyloidosis. The mortality used to be very high, with a 2 to 3 year mortality of 70%, which has now dropped down to under 50%. And we are seeing response rates in the order of 80 or 90%. The patient survival has significantly improved in patients with AL amyloidosis over the years. And patients who get a good response to therapy in AL amyloidosis will do very well. AL amyloidosis is treated either with an autologous stem cell transplant for patients who are fit, or combination chemotherapy for patients who are less fit, typically using drugs such as cyclophosphamide, bortezomib, and lately monoclonal antibodies like daratumumab. But the key we need in all kinds of amyloidosis, AL, ATTR, or AA, is drugs which will remove the fibrils. The fibrils still remain, and as long as the fibrils remain, they can cause tissue toxicity and cause progressive and persistent organ dysfunction. A number of studies were done in AA amyloidosis many years ago, but they turned out to be negative. Lately, we have got some studies going on in AL amyloidosis with antifibril antibodies, KEL-101, which has shown evidence of cardiac and renal responses in a phase 1 clinical trial. This is now in phase 3 trials. This is another antibody in patients with AL amyloidosis called NEO-001, which showed evidence of survival benefit in patients with advanced stage cardiac AL amyloidosis on post-hoc analysis. And this is also now going on to phase 1 clinical trials. It is now in phase 3 studies, and we are recruiting patients to this clinical trial. So how can we conclude? Remember, amyloidosis is a disease that you have to suspect, as there's no single diagnostic test to confirm amyloid diagnosis. You have to follow the pathway. Suspect amyloidosis, get a tissue to confirm amyloid diagnosis under the Congo red staining. Once you've shown amyloid, make sure that you do appropriate typing where possible. You then do risk stratification of the patient, and then you plan your therapy. Wild-type transthyretin amyloidosis in the elderly is increasingly and rapidly becoming the commonest type of amyloidosis. AL is almost as common, but I'm sure will become the second commonest type very soon. The two other common types are A amyloidosis, which we believe now is as common as LECT2 amyloidosis. That's a close differential diagnosis, particularly in your area of the world. Hereditary amyloidosis remain important, are seen in 10% of all cases. Don't forget to think about familial amyloidosis when there is a history. AA amyloidosis is one of the most serious complications of chronic infections and inflammations. It's unclear why only few patients get it. It is predominantly a renal disease, apart from the very, very advanced cases where other organs can be involved. Treatments center around control of chronic inflammation, protecting the kidneys, and renal replacement for patients who are on dialysis. It is really important to remember that prevention is better than cure, particularly in AA amyloidosis. Early use of biologic therapy with close control of inflammation will prevent and even eliminate this disease. It's important that all patients with chronic inflammatory diseases, particularly where the inflammation is not well controlled, should be monitored with regular renal function and proteinuria. If you start seeing albuminuria, then there is a suspicion for AA amyloidosis. Also remember, a high SAA level is not a suspicion of AA amyloidosis. It just tells you that your patient has ongoing inflammation. Presence of proteinuria changes things. So think about amyloid early, think about diagnosing it early, think about getting tissue early. Remember there is a differential diagnosis and a pathway. Chronic inflammatory conditions still remain a cause of AA amyloidosis. It hasn't gone away, but it's becoming less common. But early thinking about it and aggressive treatment of the underlying inflammation can easily eliminate and maybe even make this an extremely rare disease. Thank you all for your attention. And I want to thank all my colleagues at the National Amyloidosis Center, as well as the amyloidosis team at University College Hospitals. Thank you very much.
I think we are done for the first half of the review course. No, he's not online, and he may be back at the end of the second session. Thank you very much for bearing with us, and thank you for your kind attention. We'll be back after half an hour. Please don't be late, because we have 3 more lectures. He's not online. He's not online. It's all recording.
Professor Gafar, he is connecting now.
He's connecting now?
Yes.
Okay, Dr. Gubran? Okay, we'll connect with Professor Hadi Gubran. I'm sorry, we'll have to do without...
Probably there are many patients with amyloid which are not discovered or diagnosed. I give two short examples. In Glasgow, we had 2 elderly ladies.
Dr. Robari, I beg your pardon, Dr. Ashutosh Vishalikar is not on the line. He's not available. He sent an...
I'm on the line, sir, if you can hear me.
Oh, okay, that's great. I expected you to tell us, so thank you very much. Proceed, Dr. Robari.
We have two short examples. In Glasgow, we had 2 elderly ladies with long-standing rheumatoid arthritis and with malnutrition, malabsorption, and the biopsy of the intestine showed that they had amyloid. So it's an unusual site which may be common. And this was published in Rheumatology R in Paris. The second example is a lady, an obese lady who was seen from hospital to another for 6 years. And every time they do, because she's obese and the hoarse voice, they were doing the TSH and free T3, free T4, and were normal. And then, because of hoarse voice, we sent her for ENT, and it says there is nodule on the vocal cord. and to ask the ENT to take biopsy from the vocal cord, and it was positive for conjugate. So probably there are many cases of amyloid, secondary amyloid, or primary amyloid present in unusual places and are not diagnosed. And thank you very much.
Thank you very much for this. I think the second case that you mentioned is very likely to be a patient of localized amyloidosis of the larynx, which is not a systemic disorder and it doesn't affect any other organs. In the first case, where you found amyloid deposits on a biopsy that you did in a patient with long-standing rheumatoid, I think that's a more difficult one because it is possible for that patient to have had asymptomatic either AA amyloidosis or sometimes wild-type transthyretin amyloidosis of the elderly, and typing those amyloid deposits would be quite crucial to know what happens with that patient with the intestinal amyloid deposits.
We'll have to resume at 4 exactly. So please come back soon. I was misinformed. Yeah. We need to start immediately, please. المشكلة إن كل محاضرة مترتبة على اللي بعدها وكل واحد في بلد مختلفة تايم زون مختلف. We can't be late. Our next speaker is Professor Dr. Hadi Gubran. Many of us from Cairo University are well aware of him. His name is a familiar name as he graduated from Cairo University, Egypt, where he had his master's and his PhD or MD degree in internal medicine. He is a fellow of the Royal College of Physicians of Edinburgh. He's a fellow of the American College of Physicians, professor in Cairo University till the year 2010, where he moved to Canada and became professor of hematology and oncology at the University of Saskatchewan, Canada. He's currently adjunct professor at the College of Graduate and Postdoctoral Studies, regional advisor for the Royal College of Physicians for Egypt, then Canada. He contributed to many texts and edited the book on precision anticoagulation medicine. His main interest is in platelet cancer interactions and platelet microparticles and blood-derived biomaterials. Dr. Hadi will give us a most awaited talk on blood transfusions and blood products transfusion in autoimmune rheumatic diseases. Dr. Hadi, we are sorry for being late a little bit. We'll try to catch up. We are anxiously waiting for your presentation, so please proceed. Dr. Hadi Gubran.
This presentation was made with the help of Professor Ragab, Professor Shigashin, as well as Professor Thierry Burmouf. Transfusion and autoimmune rheumatic disease patients. In a randomly selected control population undergoing transfusion, 8.4% were found to have an underlying chronic autoimmune disorder. Furthermore, antigenic challenges induced by allogenic tissue or blood results in an immunomodulation that can trigger autoimmune diseases. It can not only trigger, but can exacerbate and worsens the outcome. The risk of autoimmune disease increased by 90% with prior transfusion without any evidence of an active infection. Patients with autoimmune rheumatic disease often present with severe anemia, necessitating blood transfusion, or may require plasma or platelet as part of their therapeutic strategies. Red blood cell concentrates are sometimes needed in the context of gastrointestinal blood loss, often associated with the use of steroids or non-steroidal anti-inflammatory agents. Also in situations of surgical interventions, particularly joint replacements, and in severe anemias of chronic disease, or when concomitant hemolytic anemia exists. Plasma, on the other hand, is used if plasmapheresis is considered a therapeutic option in certain patient groups or conditions like thrombotic microangiopathies. Fresh frozen plasma is also used in the context of concomitant liver disease or for warfarin reversal in patients with thromboembolic disease and bleeding. Platelets, on the other hand, are only used in patients with bleeding due to concomitant autoimmune or immunosuppressive induced thrombocytopenia. They are rarely used prophylactically when a critical platelet level is reached, and rarely used to increment the platelet count when patients have thrombocytopenia and are in need of the use of anticoagulation or antiplatelet agents. Furthermore, blood component therapy with platelet-rich plasma, PRP, which contains concentrated platelet collected from blood donors or separated from autologous blood, has been used locally and intra-articularly because of its demonstrable or expected benefits for the control of pain and its promotion of tissue repair and healing. And actually, these products or their use is based on the fact that the platelets are very rich in growth factors that promotes healing and neovascularization. Despite the absence of solid evidence, prolotherapy, which is the technique of using platelet-rich plasma locally, is widely used in many parts of the world to help patients with autoimmune rheumatic disease and is gaining popularity every day. When looking at the global consumption of blood and blood components, we realized that nowadays across the globe, only 1.45% of the components on blood used is whole blood, whereas the majority, more than 50% of the components used are red cell concentrate, followed by fresh frozen plasma accounting for nearly 25%, and platelets for another 20%, with cryoprecipitate representing a small minority of components used. Other components include platelet-rich plasma, as well as fibrin sealant, which is used in the surgical context. The association of rheumatoid arthritis and transfusion is quite an intriguing and fascinating topic. Interestingly, the fact that rheumatoid arthritis may be associated with a long preclinical phase during which factors involved in the pathogenesis of RA circulates peripherally has caused some concerns about the possible risk of transmissibility of rheumatoid arthritis through blood transfusion. Interestingly, at the beginning of the 20th century, many rheumatoid arthritis patients were treated by blood transfusion. Actually, this issue of relation of rheumatoid arthritis to transfusion was clarified by a very large Danish-Swedish population-based research donation and transfusion database carried on nearly 1 million donors. It was observed that 2,412 donors were eventually diagnosed with RA during follow-up, exposing 1,300 and 369 patients at least once to their blood, and 139,470 unexposed patients received blood units from the matched donors who were RA-free at the time of the selection. However, this study did not reveal that blood transfusion may transmit rheumatoid arthritis, or even more, that blood transfusion may not be a risk for rheumatoid arthritis, contradicting many other studies who have alluded to the fact that transfusion may trigger rheumatoid arthritis or at least unexpose the disease in the predisposed population. Patients with rheumatoid arthritis undergoing joint replacement may, however, be more at risk, and their transfusion requirements are higher than the control population. This fact is also true for systemic lupus, because furthermore, the presence of autoimmune rheumatic disease like systemic lupus has recently been shown to significantly lengthen hospital stay and augment the healthcare expenditure in patients having knee or hip replacement. Infections, postoperative anemia, and the requirements of blood transfusion are significantly higher in the SLE population. When we look on how transfusion can impact autoimmune rheumatic diseases, many transfusion-related factors can interplay with the recipient's immune system, negatively affecting the autoimmune rheumatic disease progression. These factors include transfusion-related immunomodulation, known as TRIM. Number 2, the role played by the complement. Number 3, the role played by the microbiome. Number 4, the role played by the iron dysregulation. Number 5, the role played by blood-borne infections. And number 6, the role of extracellular vesicles and the potential thromboembolic complications. When looking at the impact of transfusion on autoimmune rheumatic disease patients from the reaction perspective, transfusion reactions include alloimmunization, hemolytic reactions, febrile non-hemolytic transfusion reactions, and allergic transfusion reactions. Other reactions are due to TRALI, transfusion-associated lung injury, or transfusion-associated circulatory overload, or septic transfusion reactions are much less frequent. Such complications are much more pronounced in the autoimmune rheumatic disease population due to their background autoimmunity and concomitant immunosuppression. Furthermore, transfusion-associated graft versus host disease results from the transfusion of cellular blood components that contain viable T lymphocytes to immunosuppress patients and recipients who have a deficient immune system that is unable to eliminate the contaminating T cells. Transfusion-associated graft versus host disease is a serious but infrequent transfusion complication with a very high mortality exceeding 90% if untreated. When we look at the first mechanism through which transfusion can affect the recipient with autoimmune rheumatic diseases, transfusion-related immune modulation is an important factor. It is mediated by the residual leukocytes and apoptotic cells present in the transfused material, the presence of cytokines and biologic modifiers such as vascular endothelial growth factor or transforming growth factor beta, the presence of extracellular vesicles that are produced during the processing of the blood component which prime and activate neutrophil and trigger inflammation, and last but not least, the presence of free hemoglobin due to the hemolysis of the red cells together with extracellular vesicle bound free hemoglobin, which results in nitrous oxide consumption, vasoconstriction, vascular injury, and a significant enhancement of inflammation. The second element is the effect on the complement. And many factors through transfusion can lead to activation of the complement. The most important three pathways of the activation of the complement reside in the transfusion-related immunomodulation, and the second is the action of the microbiota and the microbiome of the donor, and the third is through the microbial-associated molecular patterns that are transmitted again by the donor microbiome. These will lead to the complement activation, mostly through the lectin pathway, leading to the initiation of the complement cascade that will end in the production of the membrane attack complex, the C5b-9 complex, that lead to membrane lysis and damage. It can also lead to aggravation of the pre-existing autoimmune condition. To understand more the impact of transfusion on complement activation, a study was conducted on the thalassaemic population measuring the C5b-9 complex post-transfusion and the soluble C5b-9 levels before and 1 hour post-transfusion. It was documented to be increased in 24 out of 45 patients, whereas it was stable or slightly decreased in 21 of them. Complement activation therefore can not only lead to the aggravation of the autoimmune rheumatic disorder, but may also drive many transfusion-related complications like anaphylactoid reactions, delayed hemolytic reactions, or mostly the dreadful transfusion-related acute lung injury in this predisposed immunocompromised population. The role played by the microbiome in transfusion-related complications in the autoimmune rheumatic disease population is quite interesting and intriguing. If we look on the left-hand side of the slide, you will notice that this is the donor blood. The donor blood contains a very specific microbiome fingerprint that have resulted from some translocated organisms that have penetrated the skin into the blood, many translocated organisms from the microbiota of the gut to the blood. Some of these have been processed, releasing microbial-associated molecular patterns, releasing short-chain fatty acids, releasing and consuming many nutrients, and altering many metabolites, and also generating many extracellular vesicles. All these, when transfused to the donor, to the recipient, will result in the transfusion of dormant pathogens that might get eventually activated. MAMS, short-chain fatty acids, nutrients, might affect the antigen presenting capacity and alter the humoral as well as the cell-mediated immunity, activating the B lymphocytes and resulting in the generation of antibodies and often autoantibody production. Complement is also going to be activated, and this activated complement will play in two different directions. In one direction, promoting and triggering autoimmune phenomena, and on the second, enhancing and increasing the risk of transfusion-related complications. Furthermore, the extracellular vesicles transmitted by the donor, either directly or indirectly through processing of the blood, can potentially activate the platelet and the coagulation, putting the patient at a thromboembolic risk. When looking at the role of iron dysregulation, each unit of transfused blood carries a load of 250 milligrams of iron. And knowing that the body has no route of excretion of iron, this will increase the intracellular and extracellular iron concentration, triggering the production of hepcidin. Iron is also an inflammatory mediator, and this inflammation mediated by interleukin 6 will result in further production of hepcidin. Hepcidin will block its target molecule, ferroportin, preventing the duodenal absorption of iron, preventing the mobilization of the iron from the splenic macrophages, and preventing the mobilization of iron from the hepatocytes and Kupffer cells from the liver. Overall, this iron overload will mediate a strong inflammatory reaction and will reduce or attempt at reduce the plasma iron level, resulting in a functional iron deficiency with a significant elevation of the serum ferritin. The dysregulation of iron is very detrimental to the various organs because iron is a very strong oxidative agent that can lead to an oxidative damage to most of the cell membranes, to the endothelium, and to the blood-brain barrier. This oxidative stress will also affect the pathological coagulation, enhancing and increasing the risk of clot formation, reactivating dormant organisms transmitted through the microbiome, and affecting significantly and negatively apoptosis, as well as shedding inflammagens from the endothelium, leading to the release of lipopolysaccharides and many harmful moieties that can have a very detrimental effect on the different tissues and organs, promoting a significant amount of inflammation that will definitely worsen the cases of autoimmune rheumatic disease. The role of bloodborne infections. Transfusion-transmitted infections are infections by bloodborne pathogens to a recipient because of transfusion of blood products. Various microorganisms, namely bacteria, viruses, and parasites, are transmissible through the transfusion of blood component that have not been subjected to robust pathogen reduction technology. Standard screening of donors, together with testing of donations by serologic and/or PCR, reduces the risk of transmission of common infectious organisms like hepatitis B, C, or HIV. Transmission rates are as low as 1 in 7.5 million, 1 in 12.6 million, and 1 in 21.4 million donations, respectively, in countries with safe voluntary blood donor bases and established regulatory blood collection system. Furthermore, when looking at the role of blood-borne infections, cytomegalovirus could also contribute to autoimmune disorders. And there is large body of evidence that active viral infections in various autoimmune disorders, including rheumatologic, neurologic, enteric, and metabolic diseases. In addition, CMV infection is often associated with an increased production of autoantibodies, playing a negative role in autoimmune disease progression as observed in SLE patients. Parvovirus B19 transmission, on the other hand, is associated with significant cytopenias, particularly in immunocompromised patients. To be noted that parvovirus B19 is transfused or transmitted mostly by red cell concentrates. Interestingly, dormant microorganisms transmitted through the donor's microbiome may become activated in autoimmune rheumatic disease patients receiving immunosuppression or biologicals that interfere with their defense capacity. Extracellular vesicles are instrumental in intercellular communication and connectivity and are an actor in endothelial and vascular pathologies. In a transfusion, their number and characteristics are determined by donor factors, including the donor's microbiome, the type of blood product used, its processing and storage, as well as any pathogen reduction technology that have been used on the blood product. The role played by the extracellular vesicles in transfusion-related immune modulation is remarkable, and their potential to activate both the complement and the thrombin is also to be noted. They are central in the pathophysiology of antiphospholipid syndrome and its complications, particularly the thrombotic complications. When looking at the transfusion reactions in autoimmune rheumatic disease patients, transfusion reactions are much more frequent and remain due to alloimmunization, hemolytic reactions, febrile non-hemolytic transfusion reactions, as well as allergic reactions. Other reactions include transfusion-associated lung injuries, transfusion-associated circulatory overload, and to a much lesser extent, transfusion-associated septic reactions. Such complications obviously are much more pronounced in the autoimmune rheumatic disease population due to their background autoimmunity. Furthermore, transfusion-associated graft-versus-host disease resulting from the transfusion of cellular components that contain viable T cell to immunosuppressed recipients who do not have the capacity to eliminate them will result in a serious but infrequent transfusion complication that is associated with a very high mortality that can reach up to 90% in untreated cases. When we look at how transfusion can affect an autoimmune rheumatic disease patient recipient, this can actually happen as a result of multiple mechanisms. The first mechanism is through the transfusion-related immune modulation, impacting negatively the recipient, the activation of the complement, which can have a detrimental effect on the autoimmune disorder, through the microbiome, which can result in transmission of dormant pathogens, as well as immune modulation and production of autoantibodies, through iron dysregulation, which can impact negatively autoimmune recipients through induction of inflammation and membrane damage, through the transfusion-transmitted infections and the reactivation of dormant infections, either coming from the donor blood or even from the recipient microbiome as a result of the immunosuppression induced by the transfusion. Last but not least, we have the impact of extracellular vesicles that has the potential to activate the coagulation cascade and potentially induce thromboembolic events. Furthermore, transfusion can lead to transfusion reactions, which are pronounced and much more marked in immunocompromised autoimmune rheumatic disease patients. These include hemolytic reactions, alloimmunization reactions, as well as the potential for the production of TRALIS, transfusion-associated lung injury, and the rare complication of transfusion-associated graft versus host disease with its potential mortality. The important question then is how to limit the impact of transfusion on patients with autoimmune rheumatic diseases. The first approach is through a restrictive transfusion strategy, particularly for red cells. And the restrictive transfusion strategy relies on setting a lower threshold for transfusion, which is going to be sitting between 70 and 80 grams per liter, in contrast to the liberal transfusion approach, where the higher hemoglobin concentration of 90 to 100 grams are the threshold for transfusion. Using this restrictive cutoff will reduce the amount of transfusion needs by 41%, therefore reducing the risks of transfusion-related problems. The second strategy is the one-unit strategy, often adopted in many countries, and is a valid way to reduce the number of donors to which a recipient is exposed by using a single blood unit when a transfusion is needed. In large Cochrane studies, it was documented that a restrictive transfusion threshold of 70 to 80 did not have any negative impact on patients in terms of survival, death, or quality of life. Similar to the red cell concentrate, restrictive transfusion strategies might apply to platelet. It is widely accepted now that the transfusion threshold for platelet is 10 by 10 to the power 9 per liter in the absence of active bleeding, and 20 by 10 to the power 9 per liter in the presence of bleeding or fever. This, however, is subjected to certain variations. For example, a higher platelet threshold might be needed if the patient is concomitantly taking prophylactic anticoagulation or taking antiplatelet agents. Plasma can also be restricted or substituted by processed plasma product, which will avoid exposing the patient to native blood products containing extracellular vesicle. And an example is the use of solvent detergent treated plasma, which is a safe alternative. In this technology, solvent and detergents are applied to the plasma, which is pooled, in order to eliminate viral elements and pathogens, then subjected to a very thorough filtration step, which will eliminate extracellular vesicles, cellular debris, and apoptotic cells, reducing the risk of transmission of pathogen on one hand, but also the risk of altering the immune system in the recipient. Other technologies include nanofiltration of the plasma, which is implemented in certain places of the world. Another approach to limit the impact of transfusion on patients with autoimmune rheumatic disease is to use the different tools and procedures offered by the blood bank. These includes leukoreduction, filtration, selection of donors who are CMV negative, irradiation, and washing. When looking at leukoreduction, it is widely used routinely in many countries, and leukoreduced components alone or combining CMV serology and leukoreduction can prevent transfusion-transmitted CMV for at-risk patients. In general, however, all cellular components that are leukoreduced are considered CMV safe. Irradiation, on the other hand, of cellular blood components using gamma ray source is the only effective technique for preventing transfusion-associated graft versus host disease by damaging the T lymphocyte DNA. Washing, on the other hand, is a variation in the preparation of standard red blood cell components that has undergone pre-storage leukofiltration or leukoreduction, and it is indicated in patients known to present severe or repeated reactions to blood components, and to those with isolated IgA deficiency with anti-IgA antibodies, as well as those with autoimmune hemolytic anemia. Since patients with autoimmune rheumatic disease are more at risk for reactions, a very careful cross-match and a donor selection has to be made by the blood bank to reduce these risks. Similar to solvent detergent treated application on the plasma, pathogen reduction technology have evolved significantly over the last years, and many technologies are now applicable to the different transfusion components, including plasma and platelet, enhancing their safety. They include solvent detergent technology, heat treatment, nanofiltration of plasma, and solerin and methylene blue for platelet. All these technologies reduce the potential of transmission of infection, but also eliminate many of the unwanted cellular component and extracellular vesicles through steps of filtration and processing. On the other hand, the use of industrially processed plasma-derived products, if applicable, would be the best and the product of choice, as they are on one hand very purified, targeted to the specific indication, and subjected to multiple steps of pathogen reduction technologies. For example, when we use an intravenous gamma globulin, it is heat-treated, solvent detergent-treated, as well as nanofiltered. Therefore, if we want to consider an approach to limit the impact of transfusion on patients with autoimmune rheumatic diseases, the best approach to do that would be to consider, number one, a reduced transfusion threshold, particularly of packed red cells and cellular components. Number two, reduce the number of transfused products, the 1 unit concept. Select filtered, CMV negative, or irradiated or washed units according to the indications, and irradiated units should be considered in severely immunocompromised patients, as this can eliminate the risk of transfusion-associated graft versus host disease with its very negative outcome. Also consider the use of pathogen-reduced technology-treated products, and consider transfusing industrially processed purified products, virally inactivated product, or better, recombinant product if such products are available. In conclusion, patients with autoimmune rheumatic disease often require transfusion of blood or blood-derived component, and they represent a very vulnerable population. Exposing these patients to red cell concentrate when indicated can trigger transfusion-related immunomodulation, with an immunomodulation aggravated by the role played by the donor microbiome, the complement activation, and the immune dysregulation induced by iron. This can lead to further amplification of their immune problems. Furthermore, they are challenged by the transfused extracellular vesicles that can have a negative role, particularly in patients with antiphospholipid syndrome, putting them more at risk for clot formation. Despite the very vigorous screening, infection can still represent a risk to these patients, particularly in CMV seronegative individuals or when dormant pathogens are activated. Therefore, it is important to select the product of choice for these patients and to subject, if possible, these products to the necessary tools and processes to reduce the risk of pathogen transmission. The autoimmune rheumatic disease population is also more at risk for transfusion-related reactions. One therefore has to consider, on one hand, a restrictive transfusion strategy for red cells and platelet, and if possible, resort to the numerous blood bank procedures to reduce immunogenicity and enhance safety. On the other hand, the use of industrially processed plasma-derived product subjected to filtration and pathogen reduction technology might be the best option if available, and ideally, if alternatives can be used, such as recombinant products, this would be the best option to adopt.
Thank you, Professor Gubran. We are grateful for this very lucid, informative, and perceptive description with very important recommendations for management. Actually, we are running short of time and we'll have to skip the question part. We'll ask you to be generous enough to allow those who want to ask questions to write them down and send them to your good self so that you can answer them as a written answers. Thank you again, dear Professor Gubran.
Thank you, Dr. Gag.
Among your
Thank you, sir.
Thank you very much. Our next speaker is Dr. Hamdi Ahmed. He graduated from Cairo University, where he finished his residency and got his master's degree. He had his internal medicine residency at Rochester General Hospital, and then the fellowship at the University of Alabama at Birmingham. And currently he's assistant professor of medicine at the University of South Alabama, a director of the inpatient service at South Alabama Main Hospital and Children and Women Hospital, as well as a director of adult rheumatology elective in the University of South Alabama. Dear Dr. Hamdi Ahmed, the stage is yours. Please proceed. Thank you.
Okay. Thank you, Dr. Ghaffar, for the introduction. I hope that the sound and the video are clear to everyone. Thank you all for having me today. It's an honor to be with you. So today we're going to discuss and do a review on the neuropsychiatric lupus. Let me start by saying neuropsychiatric lupus is one of the challenging diseases that we face in the rheumatology clinic, whether outpatient or inpatient. I'll start with 3 patients who I have encountered in the past year in the inpatient side. All 3 patients were admitted with new onset confusion and neurologic manifestations. The first patient, he was suspected to have lupus before the admission. Neurology team evaluated the patient and after doing extensive workup, he was suggested to have a bacterial meningitis, and he was treated for that. But he deteriorated and needed intubation in the ICU. The second patient, he's known to have lupus. He was admitted with a similar complaint, and his CSF was remarkable for just some slight abnormalities, but there wasn't nothing else in his workup. The third patient, he was not known to have lupus, and he was admitted with worsening cranial nerve palsy and conscious level. Neuro team again evaluated him, and they gave no diagnosis, but workup at that time showed positive ANA and positive double-stranded DNA. Those three patients ended up, so the first patient, we decided that this patient has neurolupus. We started the steroids, and the patient improved remarkably. The second patient, we found an aseptic focus outside the CNS, and was treated with antibiotics, and the patient improved. The third patient was actually found to have a neurosyphilis. So I hope you agree with me, it is very challenging. It's challenging on the level of patient care. It's challenging also on the level of doing research. So what we're going to discuss today, we're going to discuss the definition and classification criteria for lupus, for neuropsychiatric lupus manifestations. We're going to also discuss how to attribute a neuropsychiatric manifestation to lupus. We're going to discuss pathogenesis and diagnosis, and finally treatment. I have no disclosures. So what's neuropsychiatric lupus? According to the ACR definition, it's the neurologic syndromes of central, peripheral, and the autonomic nervous system, and psychiatric syndromes observed in patients with lupus. Which other causes have been excluded? This is very non-specific definition. If we go back in history, neuropsychiatric lupus was first described by Dr. Kaposi in 1872. At that time, he described patients who had lupus and they had disturbed conscious level, then deteriorated into coma and death. When brain biopsies were done, they showed atrophy of the brain and edema of the meninges. 100 years later, there was the first publication that tried to do classification criteria for neuropsychiatric lupus. And at that time, they considered 8 clinical manifestations. Then in 1982, the ACR published the lupus classification criteria. Neurological domain at that time included only seizure and psychosis. There was no definitions, but only exclusion criteria. In 1985, another study tried to classify neuropsychiatric lupus syndromes into major and minor. I'm going to go through these later on. In 1987, an international meeting just for neuropsychiatric lupus, they discussed that there is a potential 52 clinical syndrome that could be related to lupus. Finally, in 1998, there was another new classification that tried to classify neuropsychiatric symptoms into either focal or diffuse. So this tells you that it is truly non-specific, and we don't have a way to classify a certain symptom, or we don't have a way to tell if a certain symptom happening in a lupus patient, is it related to lupus or not. Then the ACR tried to work on this problem. So they expanded the classification criteria in 1999. And at that time, they included a 19 syndrome with main classification of central and peripheral. In the central nervous system, we had aseptic meningitis, cerebrovascular disease, demyelinating syndrome, headache, movement disorder, myelopathy, seizures, acute confusional state, which is delirium, anxiety, cognitive dysfunction, including dementia, mood disorders, including depression, and psychosis. Peripheral nervous system, it included the acute inflammatory demyelinating polyradiculopathy, which we call it Guillain-Barré syndrome, autonomic disorders, single and multiplex mononeuropathy, whether it's single or multiplex, myasthenia gravis, cranial neuropathy, plexopathy, and polyneuropathy. Let's go through one of the syndromes that they described. So we're going to go through the headache. They define headache as discomfort in the region of the cranial fold. They give us few types. So there is migraine, tension headache, cluster headache, headache from increased intracranial hypertension, and non-specific intractable headache. They even went further, and we can dive deeply into migraine. I'm sorry. And they give us more definitions or clinical features of migraine. So there is a migraine without aura, and this is the clinical feature of it, and there is aura, and this is the clinical features of it. It is similar to what the neurological definitions for these syndromes. Then they go on and they give you exclusion criteria. So you have to exclude multiple other secondary causes. So aseptic meningitis, drug-induced pseudotumor cerebri, infections, tumors, traumas, hemorrhage, medication withdrawals, seizures, and go on. So this tells us that, and they go through all the 19 syndrome. So it's a publication of 100 pages. This tells us that it's, again, it's with, I'm sorry. Yes, so later on the ELR, they came on and they added a new classification. So they classified the neuropsychiatric syndromes into diffuse and focal. Diffuse ones included aseptic meningitis, demyelinating syndromes, headaches, confusional states, anxiety, cognitive impairment, psychosis, and more. Everything else was considered as focal. So did the ACR classification criteria and this new nomenclature, did it help? Did it help in terms of adding patient or getting patient into clinical studies? When we looked in 2011, a systematic review looked into 17 single center studies with more than 5,000 lupus patients. The neuropsychiatric manifestations were noticed to be on average on 28% of the patients, but it ranged from 2% up to 94%. They noticed also that the retrospective studies had lower incidence of neuropsychiatric lupus, while the prospective studies had a higher incidence. And the most frequent CNS manifestation at that time was headache with 12%. Mood disorders, seizures, cognitive dysfunction, and cerebrovascular disease were all above 5%, and all the rest were below 5%. Okay, then in 2012 came another classification criteria, and they included more syndromes this time. So the SLIC criteria, they included seizures, psychosis, mononeuritis multiplex, myelitis, cranial and peripheral neuropathy, and acute confusional states. Then in 2019, EULAR and ACR, the new classification criteria, that was based on a scoring system, it included delirium with 2 points, psychosis, for which you get 3 points, and seizures, for which you get 5 points. So this adds a lot to the confusion of the rheumatologist. So let us ask the question in another way. How can we attribute a neuropsychiatric manifestation to lupus? So a lupus patient coming to the inpatient or to the outpatient, is there a way we can tell if this new onset and neurologic syndrome related to lupus? There have been few trials for that. So the first trial was in 2001, Ainia and his colleagues. That was a study in Finland, and they looked at lupus cohort versus control cohort. And they found that when you apply the ACR criteria, you get a 91% of prevalence of neuropsychiatric manifestations in the lupus cohort versus 54% in the controls. This has a specificity of 46%. So they needed to, or they suggested to remove some of the non-specific symptoms. And at that time, these non-specific symptoms were headache, anxiety, mild depression, mild cognitive impairment, and polyneuropathy, if not confirmed with nerve conduction study. With that, the prevalence of neuropsychiatric manifestations were lower to 46% in the lupus cohort and 7% in the controls. The specificity were up to 93%. So that's the first one. The second one was Henry et al. He's a Canadian rheumatologist, and that was in 2008. They studied around 900 lupus patients. And they looked at 3 different factors. The first factor is the onset of the neuropsychiatric event. The second factor is whether there is an exclusion factor that was defined by the EGYSIR nomenclature criteria in 1999. The third factor is whether there is a minor event that was defined by Aneurysm. And they came up with few attribution models. The most stringent one, you get a neuropsychiatric event related to lupus when this event starts or onset between 6 months before and 15 months after lupus diagnosis. There is no exclusion as defined by the EGYSIR, and this event is not one of the minor events. Then in 2015, another trial to make this attribution better came the Italian algorithm. So that was a study in Italy, and what they did, they brought first a training cohort. It included lupus patient and experienced rheumatologists. They came up, they generated the algorithm, and then they used this algorithm in another validating cohort that included physicians who are not experienced, trying to see if that algorithm is going to be helpful in making the diagnosis. And it included 4 items. The first item on this algorithm was, again, the timing. So if it's before 6 months, you get 0. If after 6 months of lupus diagnosis, you get 2. If it is within 6 months before and after lupus diagnosis, you get 3. Also, if this is not one of the minor, then you get 3 points. If there is any of the exclusion criteria that's related to lupus, if there is 1, you get 1 point. If there is more, then you get 0 points. 0 point. If there is none, you get 2 points. Additional favoring factors. So they came up with those factors that's related to every neuropsychiatric syndrome. So for example, they use EEG findings, they use CSF findings, and they define favoring factors for each of these neuropsychiatric syndromes. So if you have none of these favoring factors, you get 0. If you have 1 of them, you get 1, and if you have more, you get 2. And they define these cutoffs. So if you have a cutoff more than 7, then this event is likely related to lupus with a positive predictive value of 86.3. If it's less than 3, then this is less likely to be related to lupus with a good negative predictive value of 85. Another trial was in 2017. This was a study in Netherlands. And what they did, they tried to see what's the effect of multidisciplinary clinic evaluating those patients with neuropsychiatric events. So they will have a clinic in which there is a rheumatologist, neurologist, ophthalmologist, and all the patients will have the same lab workup, the same imaging studies. They evaluated patients on day 0 and then gave those patients treatment if indicated, and then re-evaluated those patients again after 6 months and repeated the assessment again after 6 months. At that time, they had more advantage because they knew what's the effect of their treatment and what was the course of the syndrome. So they ended up with 293 lupus patients and more than 463 neuropsychiatric events. Of these, they decided that in the first visit, 152 were related to lupus. However, after 6 months, 22 of these 152 were decided that they were not related to lupus. Syndromes that are not related to lupus were around 275 after the first visit. 6 of them only were decided that they were related to lupus after 6 month evaluation. And 36 patients were undefined. 9 of them were deemed to have non-neuropsychiatric lupus after 6 months. So the end result, we have 145 neuropsychiatric event versus 318 events that are not related to lupus. So in this diagram, you can see that most of the non-neuropsychiatric syndromes related to lupus, most of them are in the minor syndromes that were described by Amelia. So headaches, mood, disorders, cognitive disorders, psychosis, and anxiety, and peripheral neuropathy. Okay. Now, they actually went one step further, and they tried to did some analysis and look at the differences between the evaluation in the first visit and the reassessment visit. And then also they did the same with the Italian algorithm. So when they looked at the first and versus reassessment visit, they had actually unacceptable sensitivity and specificity and good positive predictive value and good negative predictive value. What about the algorithm? When they compared the algorithm to the reassessment visit, they ended up with a lower positive predictive value of 66%, but still a good negative predictive value. So what we can conclude from this, that multidisciplinary approaches to those neuropsychiatric patients could be very valuable. And even reassessment is also more valuable. The algorithm that was invented by the Italian group, it's still valuable. It shows that it is have more accuracy, and it still can be used mainly in research. So how can we improve our way in attributing syndromes to lupus? We need to understand more the pathogenesis, and to understand more pathogenesis, then we need more diagnostic tools. If looking at the pathogenesis of neuropsychiatric lupus, there are two main pathways suggested. It's the inflammatory pathway and the vascular pathway, and there are others. If we're going to look at the inflammation, usually the inflammation, it is suggested that it starts in the blood-brain barrier. I must say that most of our knowledge about this actually comes from animal models, especially lupus mice. So we don't have a lot of studies that were done on humans. It is understandable because it's difficult to get biopsies. So what happens is it starts in the blood-brain barrier, as I said. It starts in the So it starts in the blood-brain barrier. There is an antibodies that are targeting the antibody against the endothelial cell antibody. And these antibodies, they stimulate the endothelial cells. So they produce the ICAM and VCAM, which attracts leukocytes and move these leukocytes into the brain later on. So when these endothelial cells gets activated, they become more permeable to other immune cells. Also, they also start to. We also start to see. They also start to produce interleukin 6 and interleukin 8, and different other interleukins inside the brain. Another way also to activate the blood-brain barrier is through the immune complex. So when the immune complexes gets deposited inside the endothelial cell, I'm sorry, I wish you forgive my pointer. I cannot control it. So it's when the immune complexes gets deposited in the blood-brain between the endothelial cells, it also stimulates this inflammation process. One other way also to stimulate this inflammation process is during infections. So gram-negative bacteria cell walls can do that, and sometimes also during stressor reactions like adrenaline can also activate these endothelial cells. All right. So once we are inside the brain, interferon alpha, which is a hallmark of lupus, and we have no medications that target interferon alpha, it starts to activate the microglia. Interferon alpha by itself can actually affect also the neurons, and it affects the synapses inside the nervous system. Microglia, this is the macrophages of the brain. So once they get activated, they release more cytokines and activate the immunologic cascade, or they attack the neurons, and they can induce apoptosis, or they can cause different damage by inducing the inflammation itself. We have also different autoantibodies that can be involved in this process. All these autoantibodies, we know that they can be either present in the serum, so they can be in the serum of the lupus patients and then translocate into the CSF and inside the brain, or they can be generated within the brain itself, the brain tissue itself. So we know that because some of these cytokines in neuropsychiatric patients, they are elevated in the CSF and not elevated in the serum itself. However, the effect of these autoantibodies, it all comes from mainly animal studies. So if we take some examples, we have the anti-aquaporin 4, and this is the main antibody in transverse myelitis. It is actually found to be up to 30% in lupus patients who develop demyelination and transverse myelitis. The anti-NMDR that binds to the NR2 receptor can cause apoptosis of the neurons. It can also cross-react with the NSPA, the one that anti-ribosomal antibody binds to. And for the anti-ribosomal antibody, for example, we know that it is more prevalent in lupus patients who gets diffuse neuropsychiatric lupus. We also have other antibodies. There are actually tens of studies about these autoantibodies in lupus patients. But the problem with most of these studies is that they are mainly cross-sectional studies. So they do not look for a causative role, but more of like a correlation or association role. All right, so the inflammation that happens in the brain does not happen only in the blood-brain barrier. It can also happen in the CSF meningeal barrier. This is where the CSF gets reabsorbed into the subarachnoid vessels in the subarachnoid space. We also knew recently that about the lymphatic circulatory system that can also be involved in some of these, starting some of this inflammation inside the brain. So the lymphatic system acts as if it's like a pseudo-lymphatic system of the brain. We have also the blood-CSF barrier, which lies in the choroid plexus, where the CSF is produced. So any of those four areas can be the trigger or can be the start of the inflammatory process. All right. One important antibody that I wanted to discuss separately is the antiphospholipid antibodies. Antiphospholipid antibodies, they are linked to different neuropsychiatric lupus manifestations. They have a very well-established role already in thrombus formation in antiphospholipid syndrome. We know that there is some linkage between antiphospholipid antibody and accelerated atherosclerosis. Although this is not like completely established, but what happens, antiphospholipid antibodies bind to the endothelial cells and they trigger inflammatory changes that might lead to atherosclerosis changes. We also know that these antiphospholipid antibodies are related to neuropsychiatric events like seizures, chorea, myelopathy, and cognitive dysfunction. And all of these are not related to thrombotic events. These are some examples of other antibodies that were studied in neuropsychiatric lupus patients. All right, so if we take the other pathway, we have accelerated atherosclerosis. So lupus patients are well known to have an increased traditional risk factors compared to their matched controls. So they have more hypertension, more obesity, more dyslipidemia, more diabetes, and more smoking. They also have this sedentary life that sometimes it's not a choice. So they have arthritis, fatigue, anemia, and avascular necrosis. As I just suggested, there is some suggestions for roles of different autoantibodies. And there is also a suggestive role of disease activity. So they looked at in different studies, they looked at disease activity in lupus and tried to correlate this with the intima thickness of different arteries in lupus patients. But the results were not conclusive because the studies are changing between one to other. Okay, some other authors suggested that there is a role for genetics. So when they did the genetic-wide association studies, they found that there is some single nucleotide polymorphism in neuropsychiatric lupus patients more than lupus patients. There is some of these in SNPs and the TRIX1 gene, and those were found to be associated with more seizures. Also, there is a SNP found in the STAT4 pathway that's associated with strokes, similarly a subtype of the HLA-DRB1. Finally, there is unexplained structural changes. So in the brain of lupus patients on the MRIs, there is usually, you can see that there is some structural changes. They are not well explained by either an inflammatory process or a vascular process. There is some speculations. It is proposed that these could be a chronic inflammatory changes that we are not able to detect, or could be a decrease in healing after the acute injuries happen in those patients. All right, one of the most important studies that came recently, I think it helps us a lot to understand the pathogenesis of neuropsychiatric lupus. They looked at post-mortem histopathology. So they found 16 lupus patients and 16 lupus patients with neuropsychiatric syndromes, 18 without neuropsychiatric syndromes, and 24 controls. As you can see, 70% of the neuropsychiatric lupus patients had cerebrovascular disease. And then they looked at their pathology and they tried to come up with a quantitative or semi-quantitative analysis of this pathology so they can compare it. And what they found that neuropsychiatric lupus patients, they have more microthrombi, more macroinfarction, and more vasculitis. Also, they found that neuropsychiatric patients have more diffuse vasculopathy compared to lupus uncontrolled who had more focal vasculopathy. With regards to the vasculitis, it's interesting because it was in 6 patients total. 5 of them were in the neuropsychiatric group, and 4 of them had cerebrovascular event. So this opens the question, could it be that the cerebrovascular events, the strokes that happen in lupus patients, are related to a degree to vasculitis? And there is some linkage between both pathways. We noticed that in lupus and neuropsychiatric lupus, there is more deposition of the complement degradation products or immune complexes. Microthrombi were uniquely in neuropsychiatric lupus, and these were also associated again with complement degradation. When they looked, they used the MRI before doing the pathology. So they used a good machine, 7 Tesla MRI. And they tried to look if they can identify lesions before doing the pathology studies. And they couldn't find most of the small vessel injury that were visible by histopathologically. So this tells us that currently we could be missing a lot with the imaging modalities that we're having. All right, so how can we make the diagnosis? To the best evidence that we have, we're trying to come up with a few steps. So the first step is try to rule out infections, metabolic disturbances, endocrine, and drug adverse reactions. Then try to look at the CSF, you can imaging, or you can use also EEG and nerve conduction studies. Remember that with CSF, it is actually abnormal in 50% only in lupus patients. So it is not specific and not sensitive. And even the findings with neuropsychiatric lupus are similar to the findings with any other inflammatory condition. So why we do the CSF? It's mainly to rule out infections. Multiple cases you discover HSV or one of the other viruses in the CSF when it is done. What you need to order or what you need to get when you get a CSF study, so opening pressure, trying to rule out any increase in intracranial hypertension. You want to get cell count and differential. Usually you expect with lupus there will be increased cells and mainly lymphocytes. Glucose, it's usually less than 30. It's usually above 30, so it's lower than normal, but it's usually above 30. If it's lower than 30, infections should be considered. However, you have to keep in mind that glucose changes between, you have to correlate between serum and CSF glucose. Usually the CSF is between 0.5 to 0.8 from the serum glucose. Also, you get total protein and you get cultures, and these are the most important studies, so the infectious workup. What you can order from lupus standpoint, you can get oligoclonal bands and IgG index. So with those, you can, if you find elevated abnormal oligoclonal bands that in the CSF and not in the serum, this can tell you that there is an inflammatory process inside the CSF, inside the brain. If there is, the IgG index is elevated more than 0.9, then this is likely when it is elevated, and that's what we expect or is expected in lupus patients or any other inflammatory condition. I'm leaving here the formula to calculate it. I struggle a lot to find it sometimes. And then you can also rule out other autoimmune diseases, especially if the diagnosis of lupus is not well established. So we order sometimes the autoimmune encephalitis panel. And we, again, if you can order ANA, you can order anti-ribosomal antibodies, but there is no consensus on those. So what about MRIs? At this point, MRI remains the best imaging modality that we have that can allow us to look into inflammatory changes. There are different techniques that we can use at this point, but the sensitivity and specificity in lupus remains low. There are now newer techniques in MRI, and if you go through the literature, you will see in the past 2 or 3 years now more MRI techniques, like for example the DTI, the MRIs directed to just evaluate the hippocampal volume. There are new findings. For example, they found that some areas of the brain have low blood flow in neuropsychiatric lupus patients compared to controls. But still, the utility or what we can do with this information is we're still not there. All right. So if we can go through the management. To the latest guidelines that we have on lupus is in ULAR 2019, and in this guidelines, they say mainly 2 things. So the first item you have to attribute to lupus, and this is what we have discussed all through this presentation. Second is to treat with glucocorticoids or immune suppressive if inflammatory process, to treat with antiplatelet or anticoagulant if this is a thrombotic event or antiphospholipid related event. But they do not give us any more details. So going through different, the best evidence that we have so far on management of neuropsychiatric lupus, in terms of prevention, hydroxychloroquine remains maybe the best medication that decreases the incidence of, for example, seizures. That's a result from the Pneumonia cohort. But also it decreases the overall activity of lupus. And by this, we're decreasing the activity of neuropsychiatric lupus, where hopefully, if there are suggested rules that we are reducing accelerated atherosclerosis, plaquenil can play a role in this. And also it plays a role in decreasing, it has like an antithrombotic role as well. The other one that was suggested is also statins. That's mainly to prevent accelerated atherosclerosis when the patients are indicated for it. But some authors propose that there is some other immunomodulatory effects by reducing some of these inflammatory cytokines, and especially adhesion molecules. But this is not well established as well. So what do we treat with immune suppression? Acute confusions, aseptic meningitis, myelitis, psychosis, cranial and peripheral neuropathy, other conditions, if there is a generalized lupus activity. So if the condition that you're treating is not one of these 5 ones, but there is a lupus activity somewhere else, then you can consider that or keep it in the differential diagnosis that this neuropsychiatric syndrome could be related to lupus or inflammatory activity. Antiplatelets, so this, again, as we just said, that will be mainly for cerebrovascular events and antiphospholipid-mediated, again, vascular events. The role of prophylactic antiplatelets remains controversial, especially that we know also from antiphospholipid syndrome. There are some studies that suggested that it has a benefit, but other studies did not suggest the same. We sometimes underutilize the other symptomatic therapies. We need to use our neurology colleagues, ophthalmology colleagues, psychiatry colleagues because we need to, these patients might need a better adjustment of their anticonvulsants, antidepressants. We also need to control where their hypertension, diabetes, and any other metabolic abnormalities. This is not a guidelines. It's suggested by the same Italian group who give us the algorithm for neuropsychiatric lupus. So if there is a suspicious for neuropsychiatric lupus, what they suggest, if it is severe, so if it is severe symptoms, then you can give high dose glucocorticoids and IV cyclophosphamide at that time. Then you keep reevaluating. If there is still no response, you can continue IV cyclophosphamide every month for the next year and a half. Or you can switch to rituximab if there is no good response. Sometimes the response, or sometimes there are relapses, then at that time you can consider rituximab. IVIG and plasmapheresis, it is suggested here in this algorithm. However, there is not a lot of good data on these. These are all coming from mainly case reports and observational studies. If the patient responds well, then they can be on any of the azathioprine, mycophenolate, cyclosporin, or even low-dose steroids. Similarly, if you are on the antithrombotic, if you are on the vascular pathway, and those patients should be treated like any other stroke or any other cerebrovascular event. If there is, so you will give antiplatelets. However, if there is antiphospholipid antibodies, these are positive, then anticoagulation should be considered. Right. Few words on each of the syndromes. So headache, remember, lupus headache should be treated like any other headache. If there is any red flags, then at that time we proceed for more workup. Cognitive dysfunction, we need to utilize more the psychoeducational therapies for these patients to prevent further deterioration. And there is some weak evidence that this can help the patients and prevent deterioration. For seizure disorders, it is interesting that in lupus patients, they get seizures usually with single time attack, and it usually happens around the time of the lupus diagnosis. If there is no secondary causes like brain structure changes, you can consider stopping the anti-epileptic medications later on. However, if there is a recurrence of the seizures, then at that time long-term or lifelong treatment should be considered. Immune suppression and anticoagulation only routinely should not be considered. For myelitis, remember, this is like an emergency. You need to treat as soon as possible. So high-dose steroids and cyclophosphamide. Optic neuritis, that's usually in lupus patients, it happens bilaterally. Remember that the main differential diagnosis is ischemic optic neuropathy, and this usually happens unilaterally. And if it is associated with antiphospholipid, it could be associated with antiphospholipid antibodies. Finally, peripheral neuropathy. In this, we need a confirmation by a nerve conduction study, and in severe cases, you need immune suppression. So I want to conclude by saying we had advanced in the past 2 decades, maybe, in the understanding the pathogenesis of neuropsychiatric lupus. We still need to advance more in imaging and laboratory techniques, and we need more collaborative studies, more collaborative prospective cohorts to better characterize these neuropsychiatric manifestations. Finally, we need an accepted guidelines for diagnosis and management of different neuropsychiatric syndromes. With that, I want to thank you all for coming today. Thank you for the EGYSIR committee, and thank you for the organizing committee, and thank you, Dr. Ghaffar Ragab, for the invitation.
Thank you, Dr. Ahmed, for this very nice presentation. It covered most of the topics that hang in our minds. So actually, we wish to ask you so many questions, but we're running late, so we'll proceed to the last presentation. It's a recorded presentation, but I hope that we reach the time allowed for us by Dr. Kenneth Sag to interact with him on the line. Kenneth Sag is currently the Waters Endowed Professor and Director of Clinical Immunology and Rheumatology Department at the UAB. He's Director of the 2 UAB Research Centers, the Comprehensive Arthritis, Musculoskeletal, Bone and Autoimmune Immunity Center, and the Center of Research Translation in Gout and Hyperuricemia. His research focuses on the comparative effectiveness and safety of therapeutics and methods to improve the quality of care in gout and osteoporosis. He's a leading authority in osteoporosis causing conditions. His contributions led to current prevention and treatment guidelines. He published over more than 400 peer-reviewed manuscripts and methods, and authored more than 150 reviews, editorials, and book chapters. Furthermore, Professor Sag he has received numerous awards, including the Department of Medicine Research Award, the American College of Rheumatology Research Foundation Excellence, the European Calcified Tissue Society Excellence in Research Award, and the University of Iowa School of Public Health Distinguished Alumni Award. He was elected to the Association of American Physicians. He is the current president of the American College of Rheumatology and the past president of the National Osteoporosis Foundation Board of Trustees. We are glad and privileged by having him as a contributor to our review course. So please start the recording. I hope we can catch up with the online part of it. Go ahead.
Hello, and thanks for the opportunity to participate in your annual rheumatology meeting. I want to thank the organizers, and particularly Gafar Ragab, an alumni of my institution, University of Alabama at Birmingham, for the kind invitation today. Here are some disclosures. And this is what I would like to cover in this lecture. I'd like to talk about some of the things that have happened, particularly in the last few years in the COVID era. I'll allude to a few other things that are a bit older, but most of the studies that we'll be reviewing have occurred since 2018, and talk a little bit about vitamin D and calcium, some of the controversies around bisphosphonates, denosumab, and some interesting new data around osteoanabolic therapy. Now, to get us started, we can turn back to this very important quote from Professor John Canis, one of the fathers of modern osteoporosis. He reminds us that we're not doing a very good job of delivering healthcare. It was interesting because just this past week at the American Society of Bone and Mineral Research meeting, there was a study similar to the one down below by Dan Solomon, showing very low rates of treatment after a fracture, the group of people that we want to really address the best. And the new study shows that it really hasn't improved that much. It varies internationally, anywhere from 15 to 50%, but no more than half the people after a fracture in most parts of the world are getting treated. And this is why that's such a big problem. This large experience out of Iceland shows us that in the first year, in particular, your risk of having a subsequent fracture is dramatically higher, and it never comes back down to the baseline after you've had an initial fracture event. So fracture begets fracture. And even if it's a vertebral fracture or wrist fracture, we worry later about the possibility of a hip fracture. Here's data out of the US showing a very nice decline from the early 2000s into the mid 2010s in hip fractures, but then this gradual plateauing. You can see the dashed line at the very top curve showing what we would have expected things to do, but instead things have in fact plateaued. And this is associated with the decline in bone density testing, the decrease in making the osteoporosis diagnosis, and interestingly, also associated with a reduction in payment for this. Now, again, the newer data shown at ASBMR suggested that in most parts of the world there has been a plateauing of hip fractures. That's the good news. But the problem is that as the population ages, we expect this to go back up. And it certainly is possible, although this is far from a causal argument, that some of this plateauing may relate to a decrease in the use of our therapies. So let me go back a couple slides here. Somehow the computer is getting ahead of itself, and just mention that there are different strategies we can take in improving quality of care in osteoporosis. And I'll review several of these today. I'll go over some of the new use for our older drugs, understanding safety, some newer therapeutics, and ultimately, although time doesn't permit today, the discussion about how to better translate evidence into practice and using system and other approaches to try to get all of us, not us in rheumatology necessarily, but all of our colleagues who see these patients doing a collectively better job. I want to start off with some controversies and some new data around vitamin D and calcium. This is a large VITAL study. This was a large randomized trial looking at a single 2,000 international unit dose of vitamin D compared with placebo. The primary endpoints are shown on the right, and these were cardiovascular and cancer endpoints. And you can appreciate that in these two papers published in New England Journal, there was no difference in those receiving vitamin D compared to those receiving placebo. Now, VITAL is a remarkable study in its size, but keep in mind that it only used a single dose. They didn't look at vitamin D in people that were truly deficient. And they also allowed out-of-pocket, or rather out-of-trial supplementation, allowing potential interested individuals who were interested in being in a clinical trial to take additional therapy. This was data published very recently, now looking at an osteoporosis endpoint. And you can see the tremendous number of fractures and the significant duration of follow-up, but the message is really quite similar. For people that are not deficient, providing supplemental vitamin D does very little additional benefit in terms of total fractures overall. Well, perhaps it's the dose. The dose maybe was too low. Here's data out of Calgary, a large, very nicely done study comparing different doses of vitamin D and showing over 3 years that, if anything, there's a greater loss of bone. This was a surprising, somewhat counterintuitive finding, but a greater loss of bone as the vitamin D dose went up. Now, the authors weren't expecting this. They didn't hypothesize this, but it might suggest that too much vitamin D, similar to too much of some of our other drugs that can block resorption and here may have effects on suppressing PTH, could actually be deleterious to bone. And this has real relevance in our osteoporosis clinics where some of our patients are taking more than they need to be receiving. Here's a bit of actual good news, and this was an institutional study of a large group, nearly 7,000 older adults who were calcium and protein deficient. And when they received calcium and protein, given compared with a control group, you see the reduction in fractures, both overall hip fractures, a decrease in falls, although no direct effects on mortality. So this in some ways mimicked a very old French study by Chapuis, showing that among those in nursing homes, if we supplement, they may actually do well because they have a baseline deficiency. This is a little cartoon back from the US. One of our former presidents and one of our former presidential candidates, back when they could get along about things like the need for at least providing supplemental milk. So let me summarize what calcium and vitamin D can do. Adequate calcium and D and protein are essential for bone health. Vitamin D may have other health benefits. Supplements won't help if you're not deficient or the dose is inadequate. Overzealous use of calcium and vitamin D may be deleterious. Calcium is best sourced from the diet. Citrate is best for older adults who may have relative achlorhydria. 1,200 milligrams a day is what we're shooting for with dietary over supplemental sources to achieve that level. For vitamin D, we want to avoid a dose that is inadequate or too high. For most adults, I just recommend what is provided in a standard multivitamin, 800 international units a day. And in terms of the 25 hydroxy vitamin D level, aim for around 20, although you may want to shoot a little bit higher because even with some of the better assays, you may find some lab to lab and some variability in that assay. And so we often target 30 to 50, but try to keep the level below that. And I realize the units vary from place to place. This is in nanograms per ml. I want to turn now to bisphosphonates. These are very interesting and somewhat unusual drugs given their skeletal retention. There's really very few other drugs we use that have a buildup in a tissue. In this case, they bind to hydroxyapatite and live in the bone. And you can see the gradual accumulation in the graph over to the right, such that if after 10 years of daily use you were to stop alendronate, you'd see this relatively slow decay in the availability of that, such that there'd still be an oral dose equivalent of 2.5 milligrams per day available to that individual. So that very interesting pharmacology, along with these possible side effects, have led some to question the duration of use of bisphosphonates. And ONJ, osteonecrosis of the jaw, and atypical femoral fractures are the ones that we've worried about the most. Here is osteonecrosis of the jaw, defined as an area of bare alveolar bone. Generally an uncommon problem, although when it's been used in the setting of malignancy, in high doses have been given as often as every month, the side effect may occur in as many as 10% of patients, but probably closer to 1 in 1,000 or 1 in 10,000 among our patients with osteoporosis. So these problems shown here, not that serious, they tend to heal. This is a patient of mine on the right who had a similar lesion in the Torulopsis palatii, which was curetted and healed just fine. Here is a patient with a much more serious problem, one who's developed a pathologic fracture of the jaw with a draining fistula. Sadly, I've seen a couple cases of this, and this can be quite devastating with a lot of morbidity and even the potential for mortality. So very rare, but this can occur. What can we do to prevent this? What are some not evidence-based, but common sense-based approaches? So first, remove oral infection, make sure that the dentures are fitting properly, try to eliminate the risk of someone developing a lesion like this before they go on to therapy. Once they're on a potent antiresorptive, and this affects not just patients on bisphosphonates, but it's been described with denosumab and even a couple reports with the new mixed antiresorptive anabolic drug romosozumab, which I'll get to in just a little bit. But we want to be aware of this, and there's not a lot of value in checking turnover marker levels because of the protracted skeletal retention. Generally, I like a patient to be off an oral bisphosphonate for a couple months before a tooth extraction or perhaps even a dental implant. But for many people on IV therapies, you might want to just time elective dental work prior to the next dose of either an IV bisphosphonate or potentially denosumab. Here's atypical femoral fractures. They're atypical because of where they're occurring. Less than 10% of hip fractures occur in the subtrochanteric area. They also are atypical because they occur with minimal trauma. They have this transverse short oblique segment with this medial spike, affect both cortices. And prior to the through and through fracture, you see this stress reaction over the outer cortex, which if you didn't know the patient was on a bisphosphonate, you'd say, aha, this looks like osteomalacia. This is a Milkman fracture, a looser zone that we learned about when we learned about osteomalacia. But this is one of the early prodromes of what happens when people have developed this associated with bisphosphonates. Now, again, a relatively rare problem. From the well-done epidemiology studies, maybe 1 in 1,000. If we look at the number needed to treat with the bisphosphonate to prevent typical fractures, it's shown here. The number needed to harm is greater for an atypical fracture. So for each of the atypical fractures that are caused, we can actually prevent 30 vertebral and 5 hip fractures. So overall, a favorable risk-benefit profile, at least based on clinical trial data. but that doesn't necessarily always reflect what we see in the real world. And here's data from a large health plan in the US showing that over time, particularly out beyond 10 years, the risk of this event begins to increase. And you see again a newer study now from Dennis Black, published recently in New England Journal. In the lower left-hand panel is the same data. To the right, you see that when you stop the drug, when you stop bisphosphonates, it tends to dissipate, the risk goes down. Now, up in the right is something of considerable interest, and this corresponds with what many of us have noticed anecdotally, and that is women of Asian ancestry, women and men, but women in particular, tend to have a greater risk of developing atypical femoral fractures. Is this a genetic predisposition? Might it have to do with hip axis geometry? We're really not sure, but this has been a consistent observation, and it suggests that among Asian women, the risk benefit may be a little bit altered, and it may be reasonable to think about this idea of a drug holiday that I'll talk about in just a minute. We can do surveillance with women who, men as well, of course, that complain of thigh pain when they've been on bisphosphonates. You want to get an x-ray, you want to do advanced imaging if the x-ray doesn't provide the answer. And even a bone density test, if the window is lowered, might detect this stress fracture, as we see in the lower right-hand picture in a very interesting report from Fergus McKiernan. The ASBMR, the American Society of Bone and Mineral Research, has suggested an algorithm for when we might want to think about taking a break or a holiday from a bisphosphonate. This would apply for people that have had 5 years or more of oral therapy or 3 years or longer of IV therapy. In red is when we would consider a drug holiday, and that requires people not having subsequent fractures and having well-preserved bone mineral density. If those conditions aren't met, as shown in green, it may be reasonable to continue the therapy or to think about switching to an alternate therapy, such as ones that we'll be going over. So the goal here, while on drug, is to lower the risk. We know that there's a higher risk of atypical fractures in ONJ on the drug. Off the drug, lowering the risk of atypical femoral fractures in ONJ, but then again, there's going to be a higher risk once you stop of developing typical fractures. And here's some data from my colleague Jeff Curtis, looking at the US Medicare population, older women, showing that particularly with drugs that have less bone avidity, like risidronate, less sticky to bone, the risk of hip fractures and vertebral fractures increases 2 years beyond a drug holiday. So it is just a temporary cessation if you're going to stop, particularly in a person that remains at high risk. This was debated recently in the New England Journal. Richard Eastel and Paul Miller both took opposite positions for a patient who had had more than 5 years of bisphosphonate and had a residual T-score of -2.6, and they both made poignant arguments about why it might be appropriate to stop or continue. So an area of some continued clinical controversy, and a very interesting article to read. The last topic on bisphosphonates is this very interesting study out of New Zealand, where women who had just osteopenia, low bone mass, T-scores between -1 and -2.5, were randomized to receive either a dose of zoledronic acid every 18 months or a placebo. And you can see that it was actually efficacious in reducing first fragility fractures, non-fragility fractures, and symptomatic fractures. You'll notice that hip fractures aren't on here. The study was likely underpowered, but it brings us back to the idea of, one, thinking about using zoledronic acid intravenously less often even than every year. And I've heard some colleagues who give it every couple years or every 3 years in people that are at lower risk. I sometimes will give every other year in a person at lower risk, just based in part on this data and the understanding that it has a very long skeletal retention. I want to turn now to denosumab, and some of you, I think, have seen our study now that looked at it compared with risidronate in steroid-induced osteoporosis and showed its efficacy, and indeed it has an approval in that setting in many countries. And despite the efficacy in bone density, there was no difference in vertebral fractures, bearing in mind that the only study in steroid-induced osteoporosis to ever show a reduction in the primary analysis for vertebral fractures was comparing teriparatide with alendronate. So it really takes a big study and a powerful drug to do that, but you get a sense here that the risks are fairly well balanced, and it does have a benefit in terms of bone mineral density. So we have new treatment recommendations that come beyond the ones from 2017. These are the ones from 2017 from the American College of Rheumatology. And you see over here the different drugs that were recommended. They suggested in this order based in part on cost considerations. But at a debate that we did back when our ACR meeting was actually live a number of years ago, we found agreement that teriparatide might be considered in the highest risk patients, those that had very low bone mass and those that had a high dose of steroids in an older age. So those would be people where you might think about using a stronger drug sooner. And we use IV bisphosphonates in many patients over oral as a way to assure adherence to therapy. So here's the first tidbit on the new steroid-induced osteoporosis guidelines. These will be out soon, but they talk initially in the website release about sequential therapy and what to do. And you can see that what is also new is now we're looking at a PTH-related peptide, which is a baloparatide, not available in many parts of the world, and then romosozumab, also a newer therapy, an osteoanabolic agent. You can see how those might fit in and what we need to do after those are used. So you can see here what happens when denosumab is stopped, that the bone density drops off relatively rapidly. And of some concern, while denosumab was great at reducing fractures compared with placebo, the risk goes back up once it's stopped. And if anything, patients had more multiple fractures even compared with placebo. So that created a safety signal that was of some concern. Now, what can we do? We have to have an exit strategy when you stop denosumab. You could give zoledronic acid, but in this very small study from a few years ago now, also out of the New Zealand group, you see that it didn't really particularly attenuate the protection just when given as a single dose. Now, many people are now giving it again 6 months later, or some, as this paper by Roland Chapelet suggested, maybe wait an additional 3 months if you're going to give a pulsatile bisphosphonate versus if you were to start alendronate and oral bisphosphonate, you might do it right at the time that you would be due for the next dose of denosumab. And you can see in yellow what happens to the increase in bone turnover and the increased fracture risk if you do nothing. So it's important to think about a bisphosphonate, and people that have had bisphosphonates before and after denosumab, shown in yellow, or bisphosphonates after denosumab, did much better in the study of over 700 individuals, followed at over 20 centers, compared with those who did not receive a bisphosphonate before nor after denosumab. The other thing that we've seen is an increase in infections, higher rates of hospitalized infections. And so that is another thing to know about, although Dr. Curtis did not see a big difference in terms of denosumab and infections in RA patients who were receiving biological therapies. This shows us the other thing that we have been more suspicious of, and that is that there can be an increase, particularly in upper respiratory infections, ear, nose, and throat infections with denosumab from this meta-analysis. So let me turn now to some controversies around anabolic approaches. And you can see here that teriparatide looks better than risedronate among high-risk individuals who had had a previous fracture. Great to see that data. This was the Vero study, and it also was effective at preventing vertebral and clinical fractures, although it did not have a significant risk reduction for non-vert fractures among these patients. Probably just not a big enough study. Interestingly, the American College of Physicians had put out a statement about osteoporosis guidelines right before this paper was published. It didn't even mention the use of these types of drugs. So while it was great that our colleagues in general medicine were putting out guidelines and they're trying to develop a new one as well, they didn't really deal with some of the nuances that we see as specialists and didn't recognize the use of anabolics. Moreover, they recommended drug holidays for people on denosumab and didn't talk about the need for sequential therapy, which we know is very important. After an anabolic, the need to add an anti-resorptive. So this just summarizes some of the safety data around teriparatide and abaloparatide and compares these two drugs. I realize again that abaloparatide is probably not available in Egypt and in many parts of the world. It's not been well marketed, and it is very similar, really much more similar than different than teriparatide. So let me turn then to another therapy that has generated a lot of interest, and that is a drug that actually targets sclerostin. Sclerostin is an inhibitor of Wnt-mediated bone formation. So this drug, romosozumab, is an inhibitor of bone formation. Sclerostosis is a rare genetic disorder resulting in a sclerostin deficiency and an increase in modeling-based bone formation. In contrast to many types of therapies, we don't usually see an increase in modeling-based formation. Modeling-based formation is what we see when people are developing their skeleton as children and young adults. But remodeling-based bone formation is really where most of the drugs do most of their work. So this ability to mimic this condition in nature, sclerostosis, with a monoclonal antibody has a very new mechanism of action. You can see the heterozygote and the homozygote patient with sclerostosis, and notice how profoundly thick the bones are. Very similar to what we'd see in osteopetrosis, but interestingly, these bones are actually more fracture resistant in contrast to the patient with osteopetrosis. And here we can compare the new monoclonal antibody, romosozumab. We're comparing it with alendronate in blue and teriparatide in red. You see that in terms of bone density, it's really profound. This is a very powerful drug in stimulating bone formation and also serving slightly as an anti-resorptive, with gains of bone density over a 12-month period at the spine approaching a little over 11% and 4% at the total hip. Compare that with teriparatide and with alendronate, and not surprisingly, alendronate looks a little bit better early on at the hip than teriparatide, which is increasing the size of the bone, but the bone is under-mineralized early on. This is an interesting and important slide because it shows us the differences mechanistically in this monoclonal antibody to sclerostin. And you see two markers of bone remodeling, propeptide of type 1 procollagen and beta CTX, a turnover marker and a bone formation marker. You see initially an increase in bone formation and then a leveling off and return towards baseline, comparing it with placebo. In terms of bone resorption, actually it declines a little bit initially and then it comes back towards baseline. Compare that now with teriparatide, which mostly stimulates bone formation but has a concomitant reduction in bone resorption, and alendronate, where the primary benefit is in blocking bone breakdown, but also slightly attenuates the pro P1NP molecule, which is indicative of its slight retarding of bone formation. This was the large pivotal phase 3 study looking at sclerostin, showing a reduction in vertebral fractures, clinical fractures, and non-vertebral fractures, at least at the 12-month endpoint, but they did not see a reduction in the secondary endpoint for non-vertebral fractures at 24 months. There were some injection site reactions, and as I alluded to earlier, some events of ONJ and atypical femoral fracture. This is an interesting study because here we're looking at quantitative computerized tomography, which allows us to look separately at the cortical versus the trabecular bone. And if you look at the middle figure, looking at the cortical bone and comparing romosozumab in blue with teriparatide in orange, you see fairly significant differences in those two compartments. So again, while teriparatide is increasing the size of the bone and then following with an anti-resorptive, fills in that new remodeling space that's been created, early on there's actually a dip in the bone density of the cortical bone, really picked up very nicely here by quantitative computerized tomography. Whereas romosozumab doesn't do that. It actually stimulates the bone density for cortical and for trabecular bone. Now, we did a study that was really somewhat of a pragmatic clinical trial. It was a study comparing initially in a randomized part of the study romosozumab versus alendronate. That was for a 12-month period, and then everyone crossed over to receive alendronate after the initial period of double blinding. And you see a 37% risk reduction in terms of the primary endpoint of new vertebral fractures, and that became even more prominent and had a 48% relative risk reduction by the 24-month time point. This was an event-driven study, so people had varying levels of follow-up. We saw in secondary analyses similar effects for non-vert fractures with the relative risk reduction of almost 20%, and even for hip fractures. Now, keep in mind that this is not adjusted for multiplicity, so this is a nominal result because it wasn't powered really for this, and it wasn't included in the stepwise gated analysis plan. But notwithstanding, really impressive data, very impressive efficacy data comparing romosozumab with the very potent drug alendronate. Now, what was somewhat unexpected in this study, and what certainly has made the news, was the cardiovascular safety signal that we saw. Now, the study was designed with a cardiovascular endpoint adjudication because there was some belief that romosozumab, the monoclonal antibody to sclerostin, might actually be cardioprotective. But in fact, we saw a 1 in 200 or 0.5% relative risk difference between romosozumab and alendronate, favoring alendronate in terms of cardiac ischemic events and cerebrovascular events. This has been a finding that has generated a lot of discussion, a lot of debate, although interestingly, another study in men also showed a slight imbalance. This was a study looking at romosozumab in men, and you can see here 4.9% risk of a cardiovascular event compared with 2.5% in the placebo in this bone mineral density study of romosozumab in men. So overall safety in these studies looked pretty good in terms of adverse events, mentioned some of them already, but there was this small numerical difference in cardiovascular adverse events in ARCH and BRIDGE. In the ARCH study, the pragmatic study that I led, could it have been due to alendronate being cardioprotective? It was an active comparator study. There was no placebo. There's been a little bit of data, such as from the Lyle study, to suggest that bisphosphonates might be good in terms of mortality. But secondary analyses of many bisphosphonate databases don't suggest that that is a likely explanation. Could it be due to chance, something that wasn't seen in the larger frame study, that pivotal study, the registration study that I showed you initially, where that cardiovascular event wasn't seen? Well, those people were at lower risk, and that is certainly a possibility. It could be that it's real, and that it just wasn't seen in a lower risk population, the frame patients who were not as sick or as old as the ones followed in the ARCH study. Now, in looking at the data, the alendronate arm behaved very oddly. There was a very non-proportional increase in the event rate, and many think that this might be possibly the explanation. But nonetheless, the regulatory agencies, particularly the FDA, and I know in some parts of Europe, for example, it hasn't gotten an approval due to the safety concern, but the FDA has issued what we call black box warning, where there's a particular part of the product label that indicates the need to do careful cardiovascular monitoring and to be aware of this and to inform patients about it. People that have had cardiovascular events in the last year probably are not very suitable candidates to receive this therapy. So it's been a pleasure to review with you the different therapeutic approaches to our therapies and to think about different drugs that we use in osteoporosis. We have anti-remodeling agents, which include bisphosphonates and the rank ligand inhibitor denosumab. There was an experiment years ago done by Merck Laboratories looking at a cathepsin K inhibitor that was discontinued due to a cardiovascular safety signal. We have PTH, teriparatide in some parts of the world, PTH-related peptide, abaloparatide, which stimulate resorption and formation. And now we've got this fairly interesting therapy, anti-sclerostin, which mostly affects bone formation, but can also have a small effect on bone resorption as well. So let me conclude by saying that bisphosphonates should be considered with respect to holidays and sabbaticals in patients that meet the definition of duration of therapy and don't remain at particularly high risk. We need to balance long-term benefits and risks in these individuals. And in many cases, we think about switching rather than stopping. Alternate therapies, such as our anabolics like PTH and shorter-lasting anti-resorptives, may be useful for patients who remain at high risk, especially when we think about the break from bisphosphonates. And thankfully, there are some newer treatment approaches, one that focuses on a potent stimulator of bone formation, although safety questions exist for this new therapy, romosozumab. Hopefully, in coming years, we'll see some new therapeutic options because the field has otherwise been a bit stagnant in terms of new drugs entering into development. So I want to acknowledge my colleagues at UAB, and again, thank you for the opportunity. I'm delighted to take questions and be available for any email chat as well about any questions that you might have. So thank you again for your time and attention.
I wonder if Professor Sag is available online.
Hello, and thanks for the opportunity to participate in your annual rheumatology meeting. I want to thank the organizers, and particularly Gafar Ragab, an alumni of my institution,
Are you able to hear
University
me?
of Alabama at Birmingham.
Thank you, Professor Sag, for this informative presentation, very incisive, very in-depth, and very inclusive. I'm glad that you're waiting with us for more than 20 minutes. I know you have many obligations. I think we have time for one or two questions if Professor Abdul Mohsen will not ask us to stop. Just one short question, please.
Beautiful, interesting. Thank you very much. What is the dose of bromosozumab and the price, and for how long can we use it? And do we need to give a drug holiday with this drug? And thank you very much.
Thank you for your question. It's a standard dose. It's given as 2 shots subcutaneously every month for 1 year. And that is the way that it's administered. It conceivably could be given a second time, but there's not data yet to support that. And it's a single course of therapy that should be followed then by a potent anti-resorptive therapy, typically either those are what the studies have tested, and it, as you saw in the ARCH study, the study comparing it with alendronate and then followed by open label alendronate, the addition of the bisphosphonate after the initial course of therapy was very important in consolidating the benefit, similar to the use of other osteoanabolic drugs.
Thank you, Professor Sag. We have another question from Professor Faiz in Shams University.
Thank you for your lecture. I want to ask you about if you have a patient with recent fracture on old age, over 60 years old, would you prefer to start with anti-resorptive or anabolic agent?
Well, thank you for your question as well. And you asked the question that was just debated at the American Society of Bone and Mineral Research meeting 2 weeks ago in Austin, Texas. That was the debate between the ASBMR and the European Calcified Tissue Society. They do a debate every year, and that was exactly the question. Is it appropriate to use an anabolic agent first? Because we know that when you use an anabolic agent first, you get more benefit than after giving it following an anti-resorptive when there's blunting of the ability to stimulate bone formation. Interestingly, it was about 70-30 in favor of using an anabolic first, and that went up very slightly after that was the pre-debate vote, and then they had the discussion and everybody presented their sides of the argument. And they voted again, and it went up to 72%. But interestingly, the group against doing it rose a little bit greater. But overall, the vast majority of people favored using it in a patient at higher risk. Now, the challenge that we have, certainly in the States, and I suspect in most parts of the world, is that the bisphosphonates are generic. They're inexpensive, relatively speaking. Whereas, although teriparatide has become a generic in the US, it's still very costly. It's inconvenient. Abaloparatide, which I don't think is available in Egypt, is also costly and inconvenient. And romosozumab is a branded drug that is expensive as well. So it's often difficult to justify from a cost healthcare economic perspective the use of one of these drugs. But in terms of the science, for higher risk patients, I think it makes sense to think about using an osteoanabolic agent first.
Thank you, Professor Sag. Thank you very much for accepting our invitation and contributing to this meeting. With your excellent presentation, we conclude our review course, and we hope to see you in person next year.
And I invite all of you to the American College of Rheumatology meeting in November in Philadelphia, where we're looking forward to hopefully seeing some of you and hoping I can visit you in person as well. So thank you so much, and cheers.
Cheers. Bye-bye. We conclude our session, and I ask the following chairpersons to proceed to the panel. Okay.